part 3. So today we have a slide seminar on benign lesions of breast. We have two chairpersons, Dr. Zillur Rahman, who's the professor and head of Department Pathology at BSMMU, Dhaka, Bangladesh. Welcome, sir. And Dr. Jaison, professor and head of pathology, SRM Medical College, Chennai. Welcome, sir. The speaker for today is Dr. Dilip Giri, who is professor at MSKCC, New York, USA. Welcome to you, sir. We also have 10 students with us to discuss the various cases which have been circulated. The webinar hosts are Dr. Anita Borges, ma'am, who is a consultant pathologist at Center for Oncopathology, Tata Trust, Mumbai, and Dr. Sumit Gujral, sir, professor, Department of Pathology, TMH, Mumbai. And myself with Dr. Leena Paul are the moderators for this session. Few reminders: if there is any connection interruption, low sound or video freezing, kindly rejoin with the same link. And if there are any poll questions, kindly answer in the chat box, and please do not send requests for annotation to the presenter. Some disclaimers, a few more. Information about the upcoming talks. We have another slide seminar coming up for the exam going students in histopathology. Faculty being Dr. Nilotpal Chaudhary, professor at AIIMS Rishikesh, along with Dr. Prashant Joshi, professor at AIIMS Mangalagiri, which is on 7th of May. And the next talk is on malignant lesions of breast. The faculty is Dr. Varsha Shah, consultant pathologist, Royal Gwent Hospital, Newport, UK. Over to you, sir.
So can I start sharing?
Yes, sir.
So thanks for having me here today, and again, good evening to all of you. So, as the title here suggests, I'm going to be discussing with you benign breast lesions. So I've selected a few cases that were distributed to all of you, and thanks for looking at these cases. I'm sure most of you have had the time to actually look and ponder over these cases. And these are, cases that are really encounters in my daily practice. And I will use these in order to focus on what issues we need to be aware of and what are the possible pitfalls. I'm sure you don't want this to be like a textbook kind of a teaching. So this is really a practice-based, learning-based effort. So as you would imagine, the focus of my talk really will be on intraductal lesions and then fibroepithelial lesions, because at least in our practice here, by and large, these form the lion's share. Pretty much every biopsy that we look at has something to do with either one of these. I know that I am addressing a mixed audience. These probably have different levels of expertise and experience. So it will be a bit of a challenge for me to give everything or something to everyone. Hopefully, you will find something interesting in my presentation. Now, I can only share from what I have. And I know that your source materials, what you see daily in your practice may not be exactly what I see over here in my practice of histopathology. When it comes to breast, obviously, our initial encounters with breast lesions, they typically begin with an image-guided biopsy. As you know, women here over the age of 40 until about 70 or 75, most of them, they undergo periodic screening every 2 years, which is generally mammography based. Now, some of these women may eventually go on to get an ultrasound. And then a subset of these, especially those who have a diagnosis on the earlier modalities, may also end up with an MRI. Now, the biopsies are guided using these imaging tools. So typically we will see either a stereotactic core biopsy after a mammography has been done, or an ultrasound guided biopsy. And oftentimes, patients who already have a diagnosis of cancer, they will also undergo MRI examination. And if they find something interesting in those MRI, like an enhancing lesion or a mass or something suspicious, then those biopsies are also sent to us. So that is really our starting point. We rarely have palpable lesions, right? And I remember that when I was in India, the approach was to take out a lump, send it for frozen section. If you called it malignant, the next step was mastectomy. Generally speaking, it would have to be a modified radical mastectomy for malignant lesions. That's not quite the case here, and I'm sure that the scene has changed rapidly in India. Unfortunately, I have not worked in India for almost 30 years now, so I'm not really abreast with what is going on there. So with that introduction, let's start with case number 1. This is in a 60-year-old female who had a biopsy of an area of enhancement after an MRI examination. And this is what was seen. So Neha, do you want to start us off by describing what you see in this slide?
Yes,
You
sir.
may restrict only to this slide.
Yes, sir. According to the history, she is a 60-year-old female. So I can see they are have had arrangements of cell are seen, and
Do you see cells very clearly, or do you see something even grosser than that at this power?
at this power I can see that different TDLUs which are.
So you are seeing these ducts, right? Which are
Yes, sir.
filled with some cells, right?
Yes, sir.
So
Yes,
these
sir.
ducts, or most of these, are packed with some cells, and then there are some that are like small cystic kind of ducts, right?
Yes.
And then
Yes,
there
sir.
are other ducts with a different kind of contour. Some of them do show some proliferation, and then there is some sclerotic stroma, right?
Yes.
So at this point, do you have any idea?
Dilip, can I interrupt you?
Yeah.
Do you have a cursor that you can use? Can you
Oh,
use
yeah.
a laser
Sure.
pointer? If you right click on the screen, you will get a pointer option.
Yeah.
Yeah, please.
Okay, so at this point, Neha, do you have any working diagnosis at this power, or you would like to see more?
So I would like to see more.
Okay, good, fair enough. So Purnima, can you tell us what we are seeing in this particular field?
I'm sorry to interrupt you.
Yes, sir.
Dilip,
There is proliferation of
I'm sorry to interrupt you.
epithelial.
Oh, yeah,
Purnima,
okay. I think Dr.
Your screen is
Sumit
not
has
full.
a comment.
Your screen is, can you see, we don't see your picture full in the screen. It's only covering half. I think you have to stop. Maybe when you shared your laser pointer, if something happened, we can only see half picture. Yeah, can you share it again? Again, once again, same thing.
No. Dilip, you know what is happening is that it is showing your screen.
Yeah.
That's it. Yeah.
No, but
Just
still, same.
now you have gone to the slide sort of view. Can you make it full screen, Dilip?
Yeah, let's see. Let me stop and come back.
Yeah.
You know, this is what is being reflected from his own screen. Is there, can you go to screen show? You know, you've got a slideshow. Do you have the slideshow menu on top?
Or maybe can you go back to laser pointer? Can you just click again and let's see? Click laser options, pointer options.
Sir, you're in a present. You are in a present mode. You need to
Yeah,
exit
that's
that
right. He's in the
presenter mode. You are in a presenter mode, so it is projecting.
That's
So
why it's
what
showing
modes
you the next slide on the right.
Hide presenter view is there.
Okay, are we good now?
Yes.
Yes.
That's right.
Yes.
Okay. So I think I was asking Purnima to describe this particular duct here.
There is proliferation of epithelial cells,
Very
and
good.
there is fenestration appearance at the periphery of the duct,
Great. Beautiful.
and the cells have eosinophilic cytoplasm and round to oval nucleus.
Okay. Gautami, you want to add something to this? Purnima
Actually,
did a
in
great
this,
job.
the ductal epithelial cell proliferation is seen in this, means a duct showing epithelial cell proliferation in which overlapping of cell is present.
Very good.
And there is
And
streaming of
these
cells.
Okay, yeah. And then, some of these nuclei show this kind of inclusions. Yeah.
Yes, sir.
inclusions, yeah.
And then some of the nuclei also. Let me go to the pointer. And some of these have grooves. So the nucleoli are variable, some are indistinct, some are not. So what's your feeling? What are we dealing with here? There is a nice inclusion here. Okay, now next slide. Arushi, would you like to tell us what you see in this slide?
Yes, sir. Sir, in the middle, there is a population of cells, and it is surrounded by
Okay,
at the periphery, sir, there are tall columnar cells. They are present,
okay,
which the epithelium is surrounded by tall columnar cells, and which is
yes.
yes, sir.
What do you see? How would you describe these spaces?
So irregular cleft-like spaces are seen.
Cleft
Yeah.
Yes, sir.
So
Yes,
somewhat
slit-like
fenestrations, right?
spaces.
Fenestrated.
Illustrations. Yes.
Right.
Exactly.
Okay. Very good. Okay. So I think based on what you have described, it's easy to make the diagnosis, right? I mean, the proliferation is quite florid, but it is quite distinctive of a benign intraductal proliferative process. And the preferred term here in the United States for this is usual ductal hyperplasia. I think I will refer to this when I come back, as we talk on this topic, and use the term UDH for usual ductal hyperplasia. I remember that when I was in UK many, many years ago, for these kinds of changes, they would use the term epitheliosis, but they are exactly the same things. So why are we talking about this? Now, sometimes, these can pose a diagnostic problems. And certainly in the United States, and I think in most of the Western world, and I believe also in India, sometimes people may turn to adjuncts, immunohistochemical aid in confirmation of the diagnosis. So here is a CK56 stain, which shows that, there is a significant population of CK56 positive cells. And the same kind of thing is seen also in ADH5, which is a cocktail of various keratins with P63 as well in it. So this P63 is the peripheral nuclear staining that you see in the myoepithelial layer. And the ducts themselves are composed of an admixture of cells which express low as well as high molecular weight cytokeratins. And this kind of combination and this picture or pattern of CK56 staining is quite typical of usual ductal hyperplasia. Now, in a case like this, you don't necessarily need to use the stain. It's probably not a good idea to use these stains all the time because it may create some problems, as we will see later. So I think the initial diagnosis has to be made by morphology. The way you describe the morphology, I think making the diagnosis in this case became easy. Now let's have a recap on what are the features of usual ductal hyperplasia. We certainly saw the intranuclear inclusions. We saw the nuclear grooves, right? The clefts, the streaming kind of, spindly kind of cells. Again, nicely fenestrated clefts here with a beautifully pronounced bioepithelial layer at the basement of these ducts. And also, sometimes, you may see actually necrosis. Now, sometimes that can be confusing. This is particularly seen in papillary intraductal proliferation. So these foci of necrosis are not necessarily indicative of any malignant process. You can occasionally see this also in benign. So what you have to focus on really is what is actually going on in rest of the duct rather than getting, obsessed with the presence of necrosis. Similarly, occasionally you may see actually a mitotic figure in the benign ductal proliferation. And I think there is no need to get overly worried about the presence of mitosis, although the standard teaching is that, when you see mitosis in any ductal proliferation, then that raises the question whether you are dealing with ductal carcinoma in situ or, some malignant kind of proliferation. But as you see here, typical mitotic figures can be seen in UDH. So that's not diagnostic of anything malignant. So here, this slide summarizes the features of usual ductal hyperplasia. So I'm just showing you some arrows to show the grooves. Again, another groove, intranuclear inclusions, and mitotic figure, and necrosis. Okay. So now we come to the differential diagnosis of hyperplastic intraductal lesion. How usual ductal hyperplasia can be differentiated from something atypical, not quite, DCIS, but somewhere in between. And the term used for that, as you all know, is atypical ductal hyperplasia. And we will go more into this a little bit, because I think that is an important part of today's discussion. And then, of course, at the other extreme end of intraductal proliferation is ductal carcinoma in situ. This particular illustration here is really an extreme end of DCIS in that this is like a high grade DCIS. It's not anything like low or intermediate grade. It is showing a lot of necrosis, which you would call like comedo type of necrosis. So this slide actually summarizes the spectrum of intraductal proliferation. And as you can see, even in this slide, that the proliferation in UDH, which tends to be somewhat jumbled up with overlapping of nuclei, some streaming of nuclei is quite, and then different kinds of nuclear or cell morphologies, all sitting inside a duct with these, kind of cleft-like spaces. And this is in contrast to what you see when it begins to become atypical, right? So in ADH, you will see monomorphism of cells. The cells, they seem to respect each other, right? They are respecting each other's boundaries, not trying to overcrowd or sit on top of one another. And also the spaces tend to be punched out or sieve-like, unlike these fenestrations here. So this is typical of ADH. Very low grade nuclear, there is nuclear atypia, but it is very low grade, and the nuclei tend to be round and nice, although they are clearly dark. DCIS, on the other hand, the cells now are telling you that we are cancer cells, right? So this is how DCIS looks. Now, sometimes, unlike the previous slide, the ductal proliferation may assume a different kind of morphology, right? They may throw these kinds of micropapillary folds. Now, the micropapillary folds in UDH will be different as compared to those in ADH. As you can see here in ADH, apart from the cellular details that we described, the monomorphism and the nice respect for each other, these folds tend to be beautiful, right? They are smooth and pleasing to look at. Unlike those in UDH, which tend to be somewhat ragged, again, the cell population will be similar to what we saw in the previous slides of UDH, right? Now here is a schema, and I think it's important to go through this because this is sort of a learning experience for all of us, especially to those of you who are in your early years of training. It makes sense to go through this. So again, this is a normal duct with myoepithelium and a single layer of epithelial cells. So this is always, a mammary duct has two cell layers with a basement membrane outside. Now, when the cells start proliferating, they will multiply and try to occupy the lumen. Now, in ADH, these cells will actually undergo certain mutations. And instead of being like a polyclonal process here, they tend to become monoclonal. And as the life history goes along further, they will now morphologically become identifiable as malignant cells. Unlike the proliferation here, which will still remain benign and may actually, at least in terms of their nuclear appearance, may share similarities with the host duct. Now this scheme, while simple, may not actually truly reflect as to what goes on in real world, right, in our real practice. And finally, of course, once the duct borders are breached, we get invasive carcinoma. Now, the progression of UDH based on the schema which we just saw would be something like this. So these are benign ducts. Something has happened to this individual, maybe under hormonal influence or some other influences. is now undergoing proliferation, but these cells are still benign. At the most extreme of this benign process, the cells will occupy the entire duct, but they will carry the features that we know can be used to identify a benign ductal proliferation. Now, similar to that, how do things happen when the ductal proliferation is atypical? So even before the proliferation began, something was happening to these ductal epithelial cells, because now they are looking hyperchromatic, they are cytologically atypical. So this is how the atypical pathway also often begins. Here is the benign breast parenchyma in the background, benign lobules. And as you can very well recognize, the cells here are different as compared to the normal lobule. So these atypical cells will now begin to proliferate, and these are the beginnings of what you would recognize as ADH. So something like this in a biopsy would be reasonable. It would be reasonable to consider that there is focal ADH already within these ducts. Of course, you have to also question yourself whether this is simply a tangential cut or this is really a three-dimensional proliferative process. So this is how you would describe progression to ADH in contrast to the benign progression. Now this progression can go on or get more complex, could become micropapillary, could begin to assume this kind of cribriform spaces, yet they will retain this, distinct feature that is a hallmark of atypical ductal proliferation and even of low-grade DCIS, in contrast to something like this, which appears to be more benign over here. Now, it's important to remember that eventually the progression will keep on happening, and then finally you will reach a stage where the entire duct is filled. I'm just trying to simplify, I mean, this is not really what things may happen, but I'm just trying to illustrate these to make our concepts somewhat clear, especially for the benefit of the beginners in breast pathology. So this is how now you would question whether I want to call something like this as ADH, or I want to consider the diagnosis of low-grade DCIS. Now that could become a problem in itself, and we will address some of those issues in a little bit. Now, I just want to point out that the progression pathway that we just saw for the atypical, that mostly applies to low-grade lesions of DCIS. It's not applicable really to high-grade. The high-grade lesions may not necessarily go through that entire kind of, historic progression. That is not the natural history. They may just, at a clinical level, you may not see those various phases. What you will see is really this kind of standout foci of high-grade DCIS with necrosis. Now, if you have seen a lot of breast pathology, you could make a case that you may occasionally see something that may explain how this stuff actually began. But for most of us, the face of DCIS, high-grade DCIS, will be something like this, whereas you may be able to see the progression when it is in the low-grade pathway. Now, I think all that said is okay, and it's nice to have this kind of academic discussion and talk about pathways and all. But in reality, when I get a biopsy of something like this, I have to scratch my head. Is this something, some juicy kind of florid UDH? Because yeah, I mean, this is showing me some kind of cleft-like spaces and the cells seem to be jumbled up. So what do I call this, right? Do I call this DCIS? Do I call this UDH? And I must admit that there are days when I get these kind of cases and I spend a lot of time doing a lot of additional studies, recuts, and of course, sharing these cases with my colleagues. And I think that is an important part of our practice. that, we should be really willing and always ready to share our cases, because, other people's insight, their perspectives might help us make a correct diagnosis. Now, in this case, as you can see, a CK5-6 cell stain shows that most of these cells, are not showing any CK5-6 staining. There are occasional cells which are probably benign, and these may be pushed around by this, sort of clonal proliferation of the ductal cells, and therefore this is at least based on what we have seen suggestive of an atypical ductal proliferation. So we are either dealing with ADH or DCIS in a case like this. So that is how we approach. Now, many times it may be easy to make the diagnosis of ADH, right? When the process is incomplete. For example, in these ducts, these are very low-grade cells. The duct is not quite filled up. So especially if this is only a focal finding, you're quite happy to make a diagnosis of ADH. Also, in these kinds of cases where only part of the duct is involved by a clonal process, it would be reasonable to consider the diagnosis, especially if the cells are low grade with cytologic atypia. Then I think one would be quite happy to make the diagnosis of ADH. Now the question comes sometimes, is this ADH or DCIS? So one of this is ADH, one of this is DCIS. Now these are the kinds of things where you have to consider the interest of the patient before making any such diagnosis. You have to look at the age of the patient, what risk factors there are, and so on, before making a diagnosis. And we will delve into this a little bit as we go along. But I'm just raising this scenario where you might be, you might find yourself in a corner. Do I call this DCIS? Do I call this ADH? Because both appear to be somewhat low-grade process. Now, if this was somewhat high-grade process, there would be no difficulty in making the diagnosis. Now, this is not something new, this kind of debate, this kind of problem, this kind of dilemma has been with us for many, many years. It certainly was there in the era before. This paper from 1991 was in the era before image-guided biopsies became a rule. And I think this is especially true now when we see all these sort of borderline lesions more commonly with all these stereotactic biopsies. But having said that, this paper was published by a giant in oncologic pathology, and I'm sure all of you have heard the name of Juan Rosai, clearly one of the greatest names in oncologic pathology. So he did a survey of 10, and I've just blacked out this portion deliberately. I didn't want to confuse by delving into lobular lesions, but these are all examples of ductal proliferative lesions, 10 lesions, and he circulated these slides to 5 pathologists. Now, these are not simply 5 pathologists. They are not like you and me, These are all dedicated breast pathologists. And clearly, some of them were in league with this particular lady that I am showing you in this slide. So these 5 dedicated, well-known breast pathologists got these slides, and look at what their diagnoses were. Some of them thought that in D1, the proliferation was atypical hyperplasia, and some of them actually thought that this was benign hyperplasia. The H stands for benign, AH for atypical hyperplasia, and CIS for DCIS. So look at how these, domains of breast pathology differed. D2, one of them actually thought it was normal. D3, 2 of them thought it was DCIS. And you can go on and on. Here is a case where 2 persons thought it was DCIS, and 1 actually thought it was UDA, right? So there is nothing to be ashamed of when you find yourself in difficulty. I mean, I have learned now doing this business for almost 40 years. I think I never feel ashamed and asking dumb questions to my colleagues because, you want to do it right for the patient, right? But I just wanted to set the scene by discussing this landmark paper by Von Rosai.
Dilip, can I interrupt you for a minute? It's
Yes.
not just about which lesion is called what by the different pathologists. Just look at pathologist E. All right?
Yes.
Look at
Yes.
pathologist E.
Oh, right.
He called nothing
Yes.
malignant. He called almost everything benign except for two. That was, I don't know whether it's he or she, but atypical hypoplasia. So if you
Yes.
send the same lesion to E, the lesion to E, you're going to get a benign diagnosis.
I
Right?
think you made an absolutely great point. And in fact, we joke on this all the time that if you want something to be a benign diagnosis, send to pathologist E. I mean, today's pathologist E, whoever he or she, maybe I'll not name that name, but if you want something to be called malignant, maybe you should send something to pathologist A because, he is likely to call everything either atypical or, so yeah.
Absolutely, Dilip. So, so much for, experts. Thank
Yes.
you. Yeah.
Okay, so now I think that brings us to this question, right? I mean, why were all those outstanding pathologists struggling, right? I mean, why is there, not to mention mortals like us, right? I mean, why so much inter-observer variability? And why do really errors happen? And is there something that we can do to mitigate this problem, at least to some extent? So the rest of the discussion will really be focused on that. Now, one reason obviously is that different people have different thresholds for atypia, right? I mean, the Earth is populated by 9 billion people or 18 billion eyes. Now, after all, atypia, I mean, beauty is in what you behold, right? I mean, somebody said that. So someone may think something is ugly, others may think this is the most beautiful thing. So for some, this may be really, really a highly malignant cell. For others, it may be, oh no, this is a benign. So we have different thresholds for atypia, and that's not going to go anywhere. When you work with a set of people over time, you tend to kind of, have some agreement when it comes to what is atypical and what is not. But then it becomes kind of communal, right? So now within the group, you have a threshold. But that threshold, as Anita pointed out, will be different from the threshold that exists in some other group, right? So you can never get around this problem. So that is going to stay, but we have to recognize that one main problem is that different people have different thresholds for atypia, and that is one of the reasons why things get called differently. Now, the other reason, of course, is that, people may have they may suffer from some inexperience. After all, we begin somewhere, right? So when we begin, obviously, we have not seen it all. And we may fail to recognize something that is probably malignant. So for example, here, one is a benign lesion and in the other is a low grade, but a malignant lesion. But if you haven't seen something like this, but you have seen something like this, you may think that, oh, okay, this looks something like that, and therefore it is benign. So this, of course, will go away when you see more and more. And after some time, depending on how much of breast pathology you see, you will get fairly good at it. So there is no need to feel proud about it, but it's something just function of experience. So for example, spending more time on this, this is lesion A, and this is lesion B, one of this is malignant. Now the lesion B is already telling us that this might be something unusual because you are beginning to see some mucin or maybe some debris here. So the lesion B actually turned out to be some sort of a low-grade DCIS in an elderly female, and it showed neuroendocrine features. So it's like a, a DCIS with neuroendocrine features, or EDCIS. Now even experts like Rosen, at some point have struggled with these kinds of lesions. So there is no need to be ashamed, but I just wanted to tell you how lack of experience can play a role in errors in diagnosis. Now, the other question, of course, and this often comes up, okay, is there a size criteria to distinguish ADH or DCIS? So let's say if the focus is bigger than so many millimeters, and it still is low grade, can I call this DCIS? And if it is
Yes.
less than that, is that ADH? Okay. Now, this was studied actually, many, many years ago by a breast pathologist called David Page. So he and Tavasoli, one of the other pathologists, now Tavasoli worked at Yale for many years. So they, based on their studies, said that, so Tavasoli opined that if there were more than 2 ducts involved, and according to Page, if the focus was greater than 2 millimeters, then that would qualify as DCIS. And these rules were made based on long-term follow-up. But of course, you can raise number of questions on these studies. Now, we don't have time to go into all those questions, but suffice it to say that this size criteria, although sometimes used, is not really the solution. So based on those rules, for example, if a lesion like here, right? I mean, this is spanning about 6 millimeters. In contrast to this lesion on a needle core biopsy is less than 2 millimeter. So based on that, although cytologically they may be similar in terms of degree of atypia, this would qualify as DCIS and this would qualify as ADH. Now, do you really want to do this on needle core biopsy? So the 2 millimeter rule or the 2 duct rule may be used, as a general guide. But, the Page-Tavasoli rule is not really used as a standalone. And you have to remember that their long-term follow-up studies, we don't even know exactly, how these lesions were graded and all. There are a number of questions. So while this use, I just want to alert you that it's not a good idea to use let's not be dogmatic about any one particular thing. That would be the take-home message. Now, for example, here is a core biopsy in a 40-year-old female. So she is a young female, right? Now I've got multiple cores here. Now there are at least 2 cores here that are showing atypical ductal proliferation. Now each of these may actually measure less than 2 millimeter. So do I want to call this ADH or do I want to call this as DCIS? Now, these are the kinds of cases which, it is best to kind of discuss in a group, look at what this woman, the risk is, does she have any BRCA mutations, do you want her to be just followed, or do you want any active treatment to be given? And also there are a number of questions that we have to address before we call. Now, can we use the term ADH focally reaching the level of DCIS? Is there any place for some diagnosis like that? So it's a lot more complicated than simply calling something as ADH or DCIS. Now, of course, nuclear grade is important in distinction. So when something is high grade, I don't care. I mean, if this is even 0.5 millimeter, this is DCIS. So please don't try to apply the rule of 2 millimeter or 2 duct for something as ugly as this. That rule is best kept at the back of our mind when you are dealing with a low grade process. Now, of course, when you are looking at biopsies, there is something that we also have to do, right? There is something like personal responsibility. You have to assure yourself that you are well informed when you are looking at a biopsy. Do you know the age of the patient? Do you know what the imaging showed? Do you know if this patient had something before? Does she have something concurrently? Does she have cancer diagnosis in the same breast at the same time? Now, it's not a good idea to look at a biopsy blinded to all that information. I mean, I think that would be some kind of, malpractice, actually. And also, when you see something which may look kind of very minimal, oh, okay, but don't brush it off, look at deeper, because you have to remember that all these foci that we see in our tissue samples, they are not like two-dimensional structures, right? They are three-dimensional. So deeper down, they may be something more substantial. So when you begin to see something more substantial, then your index of suspicion is now going to go up. So this is actually an important element in how we address intraductal proliferation. Now, sometimes, again, when you have some less experience, you may be carried away. Now, this is, I'm just showing you an example of a sclerosing lesion, which looks like some sort of sclerosing adenosis or adenosis, but it is showing some sort of cribriform structures. So is this cribriform DCIS? They look fairly round and punched out, right? I mean, especially here. So what is this? Is this DCIS? No. I mean, the cells are benign. This is actually an example of collagenous spherulosis. Now, this is like basement membrane kind of material which gets packed into these luminal kind of spaces. And if you see closely, these actually membranous structures, will tend to retract from the periphery. So you will see some kind of bridging here. This falling apart. So this is quite an important clue. So we have to look at the whole picture, not simply the architecture. You have to question whether these are malignant cells or not, and what is the background in which this whole process is happening. Now I will come back to this again in the next few slides. But if the process looks benign, then probably all these changes are benign too. Now, it's a different matter that sometimes collagenous spherulosis. Now, this is just to show you how, this can be mimicking, because you can have cribriform DCIS. So for a beginner, this might look like cribriform DCIS. Now, you have to remember that sometimes LCIS may be involved by collagenous spherulosis, or LCIS may involve a template of collagenous spherulosis. Now, why that happens, that's difficult to answer. I mean, we can muse over that. If we have time, I have some my own ideas on it. But suffice it to say that LCIS may sometimes colonize collagenous spherulosis, or LCIS may actually produce a picture of collagenous spherulosis, whichever way you want to argue that. So these cells are atypical. The important thing here is not to make the diagnosis of DCIS, thinking that these atypical cells may be actually ductal. One has to recognize that this is a lobular process. Okay. So now, of course, why all this, discussion? Why do we need to make this distinction between ADH, UDH, DCIS? I mean, obviously, there are important considerations here. Otherwise, we wouldn't be wasting time on this. So if your pathologic diagnosis is UDH, this is what you make on biopsy. Then, of course, there is no excision. The patient is called for routine follow-up whenever that may be. Now, if you call something as ADH on biopsy, this is important to remember, at least in many hospitals in the United States, they will probably excise that lesional area and will advise increased surveillance to the patient. but they will not go back. If you say that the atypical focus is close to the surgical margin, they will not re-excise because there is probably no possibility of getting around what may actually be a diffuse process. And if an occasional duct stays behind, the life history of that ductal proliferation is so low that nothing bad is going to happen in an imminent manner. On the other hand, if you make a diagnosis of ductal carcinoma in situ in a biopsy, then the patient will, of course, have an excisional surgery. Some patients may actually get a mastectomy. Of course, most of these patients will get some form of hormonal treatment, but if the grade of DCIS is high or high enough, then fortunately, some of these patients will also get radiotherapy. So it's an important point to consider before making the diagnosis of DCIS. And of course, if the foci of DCIS are close to the surgical margins, depending on how much DCIS is present near the margins, a surgeon may decide to go back and take some more tissue out because you don't want to leave DCIS behind in the breast, certainly not in the vicinity of the surgical specimen, because there is a chance that these patients may have recurrence, and God forbid, the recurrence may actually be invasive recurrence. So to avoid that, the surgeon will often go back and take more tissue out. So that is the reason why we need to know, why we make a certain diagnosis. Now, just a little bit about the use of immunostains in the diagnosis of intraductal proliferations. So markers like ADH5 or CK56, and even some of the myoepithelial markers like calponin and P63 are often used, actually, at least in the Western world, in resolving intraductal lesions. But they are useful, but you need to know what you are doing because there could be pitfalls. And I will share with you some pitfalls. Now, this is a typical picture of a UDH with CK56 stain. This is like this peppered kind of staining in the middle of the duct of a hyperplastic duct with CK56. The peripheral cells actually don't show CK56 stain. They will actually show low molecular weight cytokeratins if we use those, like in ADH5. On the other hand, if it is an atypical ductal proliferation, then most of the cells, the proliferating cells, will be negative for CK56, but there will, of course, be some residuum of the native ductal cells that will pick up the stain. And this is, I think, something important to take into consideration when you interpret this kind of stains. So here is florid UDH with this, and this is ADH with, might look like maturing because these nuclei are now darker, but obviously they are monoclonal, and this phenomenon is sometimes referred to as pseudo-maturation. Now, the question again here is, I'm seeing like different kind of cells. Is this UDH? I mean, there are some monomorphic looking cells. Is this like, what is this? Can I call this ADH, DCIS? I mean, at least I think first we need to decide whether this is an atypical ductal proliferation. Now this is actually atypical ductal proliferation because you have to make that determination morphologically. You should not wait for the stain to make that decision for you. So I think for those who are experienced with breast pathology will come to the conclusion that, yeah, this is a clonal cell proliferation which is pushing benign ductal cells around. And if I am going to do immunostains, I will not be surprised to see this CK56 positive cells because all these cells are these cells, benign ductal cells that have been pushed by this growing population of neoplastic cells. So there is a lot of squishing around going on before eventually this clone of cells will overpower and replace the entire duct. So we have to think in terms of the natural progression as we saw in that schematic diagram. So there will be points in their life history where both of these cells will be seen, and we have to make a morphologic determination whether we are dealing with an atypical ductal proliferation or a benign ductal proliferation. Please do not try to jump to these stains, because these stains may be interpreted, and they do get interpreted even in our situation. I do see cases in consultation where a diagnosis of UDH has been made, an erroneous diagnosis of UDH has been made based on this kind of interpretation of stains.
So,
Now, obviously, you cannot use these stains for high-grade DCIS. There is no place for doing any immunostaining to make the diagnosis of high-grade DCIS. This is purely morphologic. Sometimes DCIS itself may be producing CK56 producing cells, right? I mean, the basal-like cancer, those after all, will have to begin sometimes in DCIS, and this would be the counterpart of that. So don't use these stains for high grade. It's only for the low grade ductal proliferation. And I think this is where we, just before doing that, I think there is another interesting kind of intraductal proliferation, which if you are not aware of, will lead to wrong diagnosis with immunostains. So here is a case where the submitting pathologist was questioning whether it is ADH or DCIS, because as you can see, there are these highly atypical ductal cells which are populating these ductal spaces. And so before considering any alternate diagnosis, he or she jumped to the stain and ordered a CK56 stain and came to the diagnosis of DCIS, right? But this is not DCIS. For a discerning eye, what we are dealing with actually is an unusual form of LCIS, and an experienced pathologist, in order to confirm the diagnosis of LCIS, would have used the stain P120 or E-cadherin to demonstrate that this is actually an unusual form of LCIS and not DCIS. So sometimes, mistakes will happen. So before jumping to stains, if you see something unusual which you have not seen before, the first step is actually not to order the stain, but to show the case to someone in your group or someone with more experience. And I think that is one surefire way of avoiding pitfalls. And lastly, be aware of apocrine proliferation. No place for CK56 stains here. Apocrine cells are uniformly CK56 negative. Unfortunately, these apocrine proliferations can sometimes be quite confusing, because they are all benign, but they throw all these kind of, confusing proliferative architectural presentation. Sometimes they can be quite, papilloma kind of proliferation, and yet these are all benign. Sometimes, one of the problems with these apocrine cells is that they have this distinct large nucleoli, and that to an uninitiated eye might be a worrisome feature. Now, of course, you can get apocrine DCIS, and that's why we have to be mindful of this apocrine proliferation. Because here is one case of apocrine DCIS and one which is benign apocrine proliferation. Now, this can sometimes be difficult, and we have to spend time in being sure as to what we are dealing with. There are some tips that have been offered by others, like Rosen, for example. In his book, he says that if you see vacuolated cytoplasm in an atypical apocrine proliferation, then it is probably something either DCIS or at least apocrine atypia. Similarly, he said that if you see nuclear chromatin smudging or a lot of anisonucleosis, where the sizes of individual nuclei differ by a lot, and if there is necrosis, then these point to DCIS. Or if you see mitotic figures or irregular nucleolar contours, then probably it is atypical apocrine proliferation. Now, this is true and good, may help, but you have to remember that some of these very same, anisonucleosis may also be present in benign apocrine epithelium. You may occasionally see also an occasional mitotic figure in a benign apocrine. So I think we should never, I think the take-home point in all this intraductal proliferation is never be dogmatic. You can see anything, anywhere. Some features are important, should be kept in mind, but don't be governed by those alone, right? So, and I think here is another example of an apocrine LCIS, which will look like DCIS, very wild looking, but this is LCIS, and you can confirm. So I think based on your experience, you will learn what kind of stains to order. But I think before you have reached that stage, the primary thing to do is to consult experienced people. And I think with that, I will end my discussion on intraductal proliferation with this last comment. And I think if the chairpersons want to have comments or there are questions, I'm happy to break now.
Dilip, I have a question for you. This is Anita.
Yes.
You use the term clonal ductal proliferation several times when you were referring to ADH. Yes?
Yes.
Right. Now, that presupposes that usual ductal hypoplasia is not a clonal proliferation. That's number one. And number two, ductal carcinoma in situ is also a clonal ductal proliferation, right?
Yes. Yes.
So, what is this story then about ADH versus DCIS? It's obviously
Yeah.
low-grade DCIS.
Yes.
It's is it just arbitrary? Is it does it make a difference? And why are we sort of putting so much emphasis on this is ADH and that is clonal that is duct carcinoma in situ?
Yeah, I think this is a great question, and don't know if I can satisfactorily answer all of it. But I think part of it has to do with the way surgery is done, at least in the United States. Based on their clinical studies, they have come, right or wrong, they have come to the determination that ADH may be handled surgically and then the post-op in a certain way, and the DCIS needs to be handled in a certain, so that is number one. Number two, if the ADH is minimal, right? I agree that ADH is the beginnings of DCIS and we may never be able to call one from the other. To me, ADH is actually DCIS, but at a kind of substantially, it's in the early days of its life history. Now, so therefore, if again, let's go back up a little bit. If on imaging, a radiologist tells me that the cluster of calcifications are spanning 1 millimeter, and they have cored out all of that area. In the core, I see a couple of ducts that show low grade, and they may be DCIS, but they may be ADH. Now, I kind of have come to the conclusion that, okay, the radiologist has cored out everything that there was. There's probably nothing to go back. And based on what I'm seeing, I mean, it's only minimal. So it's better to call this ADH, especially if the woman happens to be someone who is 70 years old. What am I going to expect is going to happen to her if nothing else is done to this woman for the rest of her life? Now, it could become a different story if the radiologist tells me that these suspicious calcifications are spanning 10 millimeter and I am getting only 1 or 2 cores out of that. And those are again being involved by similar looking atypical foci. And this happens to be a 25-year-old lady who has BRCA mutation. So I think a lot of this is governed. So there is, yeah. So I think ADH is DCIS. It's a low grade of DCIS. But because of the practical implications, in some kind of artificial way, the pathologists are, in order to cater to the needs of a clinician, I think in some way, I would argue this kind of approach has arisen. Now, you may take a very severe view on that, and I have
No,
nothing to say about it.
I think, Dilip, this is, you cannot draw a line when you have to have, when there is a spectrum. That's,
Yes.
that's the first thing. The second thing is, I guess, that when you say something, you use the word cancer, it has a lot of baggage that goes along with it, and sometimes patients become uninsurable, or there are social implications to the word cancer. So I agree that using the word ADH, provided that biologically people realize that these are not two different diseases. They are, low-grade proliferations, which have a tendency, if unchecked, probably to be associated with low-grade invasive cancer. But anyway, I just wanted to know your views on this kind of thing, because I think it's purely arbitrary. And, we say atypical ductal hyperplasia in large ductal proliferations, which are, intraductal, and we call it ADH. We don't want to call it duct carcinoma in situ. So I think that this is all really the reason why you saw in that thing that Rosa did, inter-observer variation. It's about concepts of an individual has about what these kind of proliferations are all about. So I think it's a very, very difficult subject, and you will not get to people to agree on the more subtle cases. Anyway, thank you for answering that question.
Yeah. No, I think this is absolutely true, and I mean, a similar thing is happening with LCIS, right? I mean,
That's right. I wasn't going to get into that controversy, because today people are using E-cadherin and also your P120 and whatnot to decide what is lobular carcinoma in situ, maybe even what is invasive lobular carcinoma.
Yeah.
And to me, I think that we described infiltrating lobular carcinoma and in situ carcinoma in the days when we didn't have E-cadherin or P20. It was a morphological definition, and I don't know that this morphological definition has changed. And I know a lot of people use E-cadherin left and right and say if it is expressed, then it's not lobular carcinoma. And I disagree with that, but then we leave it for another day.
Yes. No, I think I 100% agree with all you. I think that I'll just end this with a final observation that, having spent so many years practicing everywhere, I have now come to the conclusion that, this may not be the end of it. I mean, people may revisit this, and there may be reformulation of strategies, and pathologists will respond by making different rules, and this will go on and on and on. And, this is never ending story. Okay. If there are no more comments.
Sir, do you want to take a question?
Okay. Now, I think this is something I cannot resist before ending. I think I alluded to this. I mean, this was brought out very beautifully by none other than Zopardi, a giant in breast pathology from many years ago. This book I would recommend to all the people who are training. If you can get your hands on this book, please read it. It may seem like out of date now, but there are lot of important observations made here. And one thing that he said in this book that has stuck with me even today is this: look at the company they keep. What he is saying is that if the proliferative changes seem to be in the background of what is exquisitely a benign kind of a process, then don't obsess over some minutiae. It's all probably benign. And I think that's a very important and a good comment. Okay, so let's move to the next case. So we have now here a 45-year-old female with a core biopsy stereotactic, so that is mammographic for calcifications in the right breast. So Akanksha, would you like to set us off? Start
Yes,
us
sir.
off?
This is a breast biopsy comprising of multiple dilated acini.
Very good. Breast biopsy, we are seeing benign breast here, right? Yeah, good.
Comprising of many multiple dilated acini, which are filled
Multiple
with dilated
dilated.
acini,
Yeah, very good.
and which are filled with luminal secretion, and few of them also calcifications are also seen in few of the acini.
Okay, very good.
And and then the sir, and they
Okay,
are lying
now
by.
let's I think Akanksha, you have said enough. Let's move to Amrita.
Sir, here it shows multiple ducts lined by tall columnar cells,
Very good.
which have prominent secretions are there, and apical snouts is there. Apical,
What is this? What are these?
apical cytoplasmic snouts are there, sir.
Snouts. Good. We see snouts everywhere, right? Yeah.
And,
Okay.
and one duct.
How would you describe the nuclei?
The nuclei is they have uniform ovoid nuclei.
Mm-hmm. Okay, good. Okay, now Subramaniam, you want to take it further?
Yeah. Uh, Sorry, these cells are uniform, have elongated nuclei with evenly distributed chromatin, and we can see incuspicious nuclei. In few, we can see, and apical snouting can be appreciated, sir. The cytoplasmic snouting can be appreciated.
Okay.
And with luminal secretions.
Yes, great. Okay, so the diagnosis here. So I'm going to discuss now the whole, this is another area which has proven to be quite vexatious. This whole entity of flat epithelial atypia or columnar cell change with atypia. Now, how did all this begin? Right? So we have to go to the beginning of the beginning. So all this was started by a pathologist at Harvard, Stuart Schnitt. So he, with James Connolly, so they had done, interestingly, a large study of nurses. So they probably looked at, I don't know how many, but probably even more than 1,000 stereotactic, because you have to remember, this is in 1998. And mammography actually began, I still remember I was in UK in 1988 when I attended a course on mammographic pathologic correlation. So at that time, stereotactic biopsy was still not had not even, started. So we are talking about a cohort of cases that were collected in the 90s, because that is where Schnitt and Connolly began seeing these stereotactic guided biopsies. Now, these kinds of changes that we just saw in the previous slide, they of course existed, right, forever. They were seen in the breasts of women. but they never attracted any attention because we were more focused on the breast cancer or a fibroadenoma or something like that. But now these were targeted biopsies. And these guys, they started seeing this something funny. And they made an elaborate description of what they saw. Now, in the past, if you look at some old books of breast pathology, you will see some terms like blunt duct adenosis, with all these columnar kind of changes. So it's not as if people were not seeing, but we didn't think that they mattered really, I mean, when they really started looking malignant, when something like this, I'm not saying this is malignant, but when something like this began to look malignant or very atypical, some people would have called it like flat DCIS, right? For the similar kind of changes. So these columnar cells, they are like nicely, tightly arranged here at the base of the epithelial layer. There is a nice myoepithelial layer on the outside. You will see nucleoli. Now, when they start becoming atypical, they will still kind of look similar at a very gross level, because both the typical and the non-atypical forms of columnar cell change will show themselves with calcifications and will become targets for biopsy. Now, what is different when it is flat epithelial atypia? Now, this is a classic example. You will again see those apical snouts, but now you will begin to recognize that there is multi-layering and there is loss of that, tightness that we saw in the earlier slide. So now this, there is a disarray. These are becoming now to look somewhat atypical, although low grade. There is loss of polarity, different, layers. And many times, actually, you will see more ductal proliferation in this setting of flat epithelial atypia. Sometimes it may be ductal. So now I think many of you will begin to ask whether this is actually already ADH. And a lot of you may be musing over this focus and asking the question, is this like ALH or atypical lobular hyperplasia or LCIS? Look at the way this is pushing in a pagetoid fashion, it is lifting the epithelium, this, group of cells. So this is like a pagetoid expansion of cells, which is typically seen in LCIS. So these are common associations with flat epithelial atypia. Now, occasionally, in a small number of cases, you may actually see small foci of cancer, right? Like here, we see a small focus of tubular carcinoma. So the cancers that arise in association with these foci, classically, these are low grade, kind of almost always tubular. They are small. Occasionally, they may be like lobular carcinoma, and those also will tend to be small. Because if they are big, then those cancers will themselves be targets for imaging, right? They will present as a mass or asymmetry or something like that, not so much as these discrete kind of calcifications. Now, when the foci of cancer are small, they are unlikely to be picked up on imaging. So these are associations rather than presenting things on imaging. And sometimes, you may see only this FEA kind of change in biopsy, especially if it is undersampled. And when you go back, you may see like, this small foci of cancer or ADH or DCIS. So it turns out that based on the findings done by Schnitt and Connolly, they found that in many of those patients who had excisions, they found upgrades. So when they say upgrades, what do they mean? What they mean is that although in the biopsy they saw only columnar cell change with atypia or FEA, in the excision specimen they saw things like ADH DCIS, or those low-grade cancers that I just showed you. So that is all what this whole thing is about, right? At least that is how it looks now. But in those days, based on these observations, and these were reported in the literature, people decided that you need to excise whenever there was a diagnosis of flat epithelial atypia.
Dilip,
So-
can I just interrupt you for a minute?
Yeah,
There are some
yes.
participants, I think the students, who are talking, and their mics are on. So please, please mute yourselves. Otherwise, you're disturbing everybody. Sorry about that, Dilip, but please go on.
No. Yeah, good. I was also jarred a little bit by that, but it's good that you.
Yeah, so please do not talk. I think it's Subramanian and somebody else, because I can see that your mics are on. Will you please mute yourselves if you're not answering a question?
Now, again, the funny thing about this whole discussion is it kind of similar to the discussion we just had, with that ADH and, all that thing. So what is FEA after all, I mean, is there really something that everyone can agree that, yeah, this is FEA and this is not, right? So again, it all depends on who is looking at the slide, right? For someone, this may be atypia, someone not. Even for someone, this may not be atypia, and others may be really. So I think we can never get around this problem. So what is the solution? I mean, there is no solution really. Because as Anita very nicely pointed out when we were discussing ADH and DCI, these also are part of a spectrum, right? I mean, the atypia begins because of some molecular events, and as the days go, and as the cycles go, the atypia progresses, the molecular changes progress, and now you begin to see greater degree of atypia, greater degree of atypia, greater degree of atypia, and so on and so on. So where does one draw a line? One cannot draw a line. And I think at the end of the day, fortunately, this assessment has now become observer dependent. So again, given that, I think the only really some working solution for it, although not really an absolute solution, is peer consultation and consensus. So I think at Memorial, we never diagnose anything as FEA unless it's seen at our consensus conference. Now, the other thing that has happened over the years is that given the slow natural history of FEA, right, unless the risk is perceived to be high. Now, what do I mean by perceived to be high? So, for example, if the patient already has breast cancer in the same breast or another breast, she has, other risk factors like, BRCA mutation or other things, or she is very young and has BRCA, has family history, multiple family members having breast cancer, So unless the risk is perceived to be high, such a diagnosis, at least at Memorial, does not result in excisional surgery. And, a slew of publications, after Schnitt's observations have also come to light. And here is, in a nutshell, some recent publications, in the later years. So you can see that in many of these studies, actually, the upgrade rates can even be as low as 0, maybe 2%, or overall, based on this, kind of literature survey, the upgrade rates are not that high, certainly not as high as was initially published. And when the excision shows something, it really doesn't show you something that is earth-shattering or really, you could have waited, right? A millimeter of tubular carcinoma in a 70-year-old, what is it going to do? That woman can stay happy with that tubular carcinoma inside her. Autopsy studies have shown that incidental carcinomas were there in women dying of other causes. So we are unnecessarily probably intervening to deal with a problem that does not exist. And I think furthermore, others have shown, this is a nice Mayo study, which says that when you follow this patient, as a cohort, FEA is not even independently associated with increased risk of breast cancer. So it may end up as being much ado about nothing. And we may safely eliminate doing surgeries on patients who carry the diagnosis of FEA, barring a small subset. I think what we can learn from this and what is happening now, at least, in many practices in the United States, is that when you see FEA, what you are now trying to see is, can I exclude ADH or not, right? Because once I call something as ADH, then that patient will get surgery. So if I want to push something towards surgery, I am now frantically trying, forgive me for making this kind of comments, but I am now frantically trying to find an excuse to bump something up to ADH. So even these small bridges may make me feel good, because now I can rest in, sleep well, because I am now getting this patient excised because there is ADH, and reading that report, the radiologist is going to call the patient and tell her that, hey, you need to see a surgeon. Now, is this even necessary? Now, that's something that I think we'll have to wait for another day to get an answer. Okay, so comments and questions on case number 2?
So I had a question.
Yes. Can you, Swati? Yes.
Yes, sir. So how do we differentiate between flat epithelial atypia and columnar cell hyperplasia?
Yeah, so if you don't think it is atypical, then when you use the term columnar cell hyperplasia without using the term atypical, then that is like a benign, right? So it's similar to what you would expect would happen in UDH. So it's an early stage of hyperplasia, but in a benign setting.
So is the flat epithelium and columnar cell are they synonymous?
They are the same thing, columnar cell change. I mean, what has happened and what has confused a lot of people is that a plethora of names were used in many early studies, columnar cell hyperplasia and apical snouts and blah, 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 cystic lobule. I mean, I can name many of these names. And then I think at some point, in order to bring some order to all this confusion, I think it was Schnitt who decided that a unifying term would be flat epithelial atypia. Unfortunately, even today, not everyone uses that term flat epithelial atypia, and people use like different terms. But I think everything is the same. What it means is, if you use the term atypia for these kinds of things, you are actually pointing to flat epithelial atypia.
So there are no questions regarding the second case, but can I ask you 2 questions regarding the first case? It has come in the comment.
Can you speak louder? I'm having some difficulty in hearing.
Can you hear me, sir?
Yeah, now I can hear. Yeah. First
Okay.
case, you want questions?
Yes, just 2 questions related to the first case. That is, do all cases of ADH convert to DCIS and then DCIS into frank carcinoma if untreated?
Can someone repeat this question for me? I'm sorry, but I had difficulty.
Yes, I'll ask it. Dilip, can you hear me?
Yeah, I can hear you well.
The question is, do all cases of ADH convert to DCIS and then DCIS into frank carcinoma? So what is the progression of ADH? Is it inevitable that it becomes DCIS and then invasive carcinoma?
Yeah, I think this is an absolutely brilliant question. I mean, I don't think we have any reason to believe that, although that would be like a logical way to look at it, that things will progress and eventually lead to invasive cancer. But in reality, it probably doesn't happen. And there may be molecular reasons also for that. At some point, a cell may just, undergo senescence or may decide to stop to proliferate, and the progression may be halted. So even if there is no intervention, surgical or otherwise, a particular change may arrest itself and nothing may happen. But the statistical chances of the thing progressing is there. So that's why this whole business about treating.
Yeah, I think what Dilip is saying is it's about risk, and the risk in low-grade lesions is low. And that's the same story with prostate cancer, because 3+3, you have an invasive prostate cancer, and you needn't do anything about it because you'll probably outlive, the prostate cancer will probably outlive you. And similarly, I suppose, for many of these low-grade lesions. I guess I've summed it up, Dilip.
Yeah, very nicely. I mean, we can just look at the old literature on autopsies. I mean, women harbored invasive carcinoma, not only micro-invasive, but even, and simply having a cancer doesn't mean anything unless it spreads, right? So that is where the difference is. I mean, a particular cancer may just sit silently, for years and years and years.
All right, there's another question, Dilip, because you can hear me better. I'm going to.
Yeah.
In the chat box, it says 2 millimeters or greater than 2 ducts is a very ambiguous thing, as it is difficult to make out 2 ducts, especially if a duct is big and so many sections are required, and grossly as well as difficult to make out. What are your comments?
Yeah, I think this rule should not be followed. I mean, I think I probably did not make it very clear. I mean, it's like a guideline that was based on long-term follow-up studies, but we cannot use this in clinical practice. We cannot just decide that, okay, because this is now 2.2 millimeter, it becomes like DCIS, and because it is 1.5 millimeter. No, it's not. It's nothing like that, I mean, at the end of the day, these are all low grade. So you have to consider many other things before you weigh on one side or the other. And it is totally arbitrary, totally unscientific. It's just, but we have to have some kind of guideline. And I think at this time, people have agreed that, okay, in the absence of anything more meaningful, this might be a useful way of addressing.
Okay. Before we go to the next thing, can I ask a question?
Yes.
I have never been very sure what these columnar cells with snouts are. I know it is ridiculous. Yes, we recognize that they are there, and we know that it's one of these things that may be associated with flat epithelial atypia, or whatever we are calling these lesions now. But if you look at gynecomastia, which I'm sure you have seen, and so many of us are seeing, gynecomastia is a classic case, just like in the old days you said fibroadenosis. Yeah.
Yes.
Was showed this what today we are calling columnar cell change. So what actually is columnar cell change? Is it something abnormal, or is it something that's normal, that occurs physiologically? I'm not very sure. So could you address that?
I mean, I think that people have looked at this, and what they found is that it actually, this column, the atypical, the FEA kind of cells, they actually share, they have overlapping molecular features with actually lobular, the cells of lobular carcinoma. In other words, they have loss of heterozygosity similar to that seen in LCIS. So it does appear that there is something there. What is not clear is what exactly does it mean clinically.
Okay, but you do see benign lesions. Like I said, you see gynecomastia, it has got columnar cell change.
Yeah,
and
so the column,
Yes.
Yeah.
And so does fibroadenosis. Now, quite apart from the epithelial atypia that is associated with it. What does columnar cell change actually signify, either other than it might show epithelial atypia? Where does it come from? Is it a physiological change?
Yeah, I think it came from morphologic observations. Actually, one should stop using the term columnar cell change, because columnar cell, as you just rightly pointed out, is everywhere. I mean, you can see that in any benign breast elements. So there's not a big deal. Unfortunately, we are now stuck with this terminology because of historical reasons. And unless something changes and we find a new way of addressing this, this is going to stay. But yeah, I mean, I 100% agree that one should stop using the term columnar, because columnar cell change is a normal cell.
Yes. All right. Thank you. Thanks, Dilip. I think, are there any other questions, moderators? Is there Geeta or whoever? Is there
There's
something
one more
that,
question which has come up.
Yeah,
yeah, tell me,
read out?
which one is it? Is it something
Yes.
about, so how should we comment in a core biopsy specimen?
yes,
Is
ma'am.
that the one? Yeah,
Yes, yes.
okay. So how should we comment in a core biopsy specimen if there is a dilemma between ADH versus DCIS? What should be the comment, Dilip?
Send the slide to me.
Very good, Dilip. You'll get all my cases. Thank you.
No, I mean, seriously, there is no way of answering this question. I think, I think fortunately, I work in an environment where I have a lot of colleagues who I can turn to in cases of doubt. But I think ultimately, we have to recognize that if it's a low grade process, let's not make a big deal and let's not give a scary diagnosis to someone. But I think you have to know what the patient has, what are the imaging findings and all. And I think that this is something that we only learn by looking at more such cases. I don't think there is a simple answer to your question.
Yeah, I think that was Sibli Ahmed who asked that question. I think at some stage in one's life, Sibli, you have to learn or you have to take on the responsibility of coming down one way or the other. And I think Dr. Giri has shown us what sort of parameters you have to take into question: the age of the patient, the size of the lesion, various other parameters, and then you decide which way you want to come down.
And then there's one more question.
There's one more question.
Okay. Nuclear grade?
Shall I? Yeah, yes, ma'am.
Yes, nuclear grade is different in ADH and in low grade DCIS. I don't think that is so, but Dilip, you can answer it.
Yeah, no, there is no difference in I mean, again, this is a spectrum, as Anita just, brought this out. And there is no need for the nuclear atypia to be different in ADH versus low-grade DCIS. It's more really a quantitative thing. Now, obviously, when there is ADH, there is a good chance that the degree of atypia is going to be lower than that seen in a typical low-grade DCIS. But this may be a very, very hard thing to decipher. Unless, of course, potentially AI is able to, help us out. But, that will not happen in our lifetimes.
I think we should go on to the next case.
Yeah, I agree, Anita. It's getting late in the day, and
Yes.
we could be here until midnight. And
No, that's all right, because as long as the students are happy, it doesn't matter. Come along.
Okay, great. So let's move to the next case. This is in a young girl, 21-year-old female. This was now an ultrasound biopsy of mass in the right breast. Okay, so now we are down to Sumit. Sumit, can you start us off? And if we cannot hear Sumit, we can move to Swati.
Yes, sir. So in this breast biopsy section, we can see 3 core biopsies in which spindle cells are seen surrounding and interrupting the normal breast ducts.
At this power, can you really tell confidently these are spindles? I just want you to describe to me what you see in this slide, in this image.
Okay. So we can see many normal ducts which are majority of whose lumen is not visible.
Okay, good. Are they evenly spaced kind of, or there is a large chunk where you don't see any ducts and then?
Yes, so they are not evenly spaced.
Yeah, they are not very evenly, but they are still relatively evenly. I mean, you know, like you're, okay, anyway, yeah, that's something, okay, good. What else do you see? What about the periphery?
So in the periphery, we can see some fat spaces and stromal
Is
areas
this
are
circumscribed? Do you think that this is circumscribed kind of
Yes, sir.
lesion, or it's not?
Yes, sir, it's a circumscribed lesion.
Okay, great. Okay, beautiful. So I think in nutshell, what she is telling us that we have a solid looking mass which is circumscribed and which is composed of both glandular elements and perhaps stromal elements, some of which looks pink and some of which is probably looking somewhat cellular, right? Okay, great. Okay. Okay, Siddharth, you want to take us further?
Yes, sir. So this slide is showing the proliferation of the glandular and the stromal elements, and the few of the glandular structures have been become single linear branching like due to the proliferating stroma.
Okay, so you are seeing proliferating stroma, right?
Yes, sir.
Okay. Okay.
So we are
good.
seeing an hypercellular stroma in this spectrograph.
Okay. Okay. And do you see uniform distribution of glands versus stroma or not?
No, sir.
No. It actually is fairly uniform.
Uniform.
We will get to this a little bit later to exactly when I tell you what exactly is meant by absence of uniformity. But okay. Okay. Now, Neha, I'm coming back to you.
Yes,
Can
sir.
you describe to me this?
The glands are compressed, and the stroma is having spindle cells with bland nuclei,
Very good.
and they are oval bland nuclei,
Yeah.
and
spindly, right?
yes,
They look spindled,
yes, sir.
spindle
Yes, sir.
cells. Okay.
Yes,
Okay.
yes, sir. And the glands are lined by low columnar to cuboidal epithelium, and they are compressed.
Okay. Okay, great. Do you see any mitotic figure?
Yes, sir.
You see a mitotic figure here?
Yes, sir.
Yeah, I don't see. I mean, there are some lymphocytes, but that's something that you would look for. That's okay. But yeah, you can take it from me that there are no mitotic figures in this. It's a bland, as you said, bland stromal spindle cell proliferation with evenly distributed glandular or ductal spaces. And as you said, columnar, look, these are these snouts. So to Anita's point, you know, columnar cell changes everywhere. So the diagnosis here, I think you made the diagnosis for us that this is an example of fibroadenoma, how it would look like in a needle core biopsy. Now, this brings us to the question of fibroepithelial lesion. And I'm going to spend some time discussing this because this is very important. And I think we need to have some clarity in how to address these lesions, because at one end is a totally benign, exquisitely benign thing, which probably can be left untouched after a needle core biopsy diagnosis. And the other is something which is not quite like fibroadenoma, although in a large number of cases it may behave similar to a fibroadenoma. And I'm talking about phyllodes tumor or cystos. The other name for this is cystosarcoma phylloides. I think it's better not to use this term because it unnecessarily makes it obnoxious sounding with this sarcoma in it. But anyway, so I think this is a preferred term now. So here I think is a whole mount of how a fibroadenoma would look like. Very uniform distribution of glands and stroma, circumscribed kind of lesion. It can be shelled out, probably was shelled out in this particular case. And when you look at it closely, the stroma will appear to be not doing much in a classic case. Although there can be a lot of variation and there is a spectrum of degree of cellular change that can happen in a fibroadenoma. But they all are classically circumscribed. And the distribution of glands versus stroma is pretty much uniform. And I think when this nomenclature began, some of the early pathologists, they hypothesized that fibroadenomas, they arise from the specialized lobular stroma. So probably fibroadenomas, the cell here arises from this specialized stroma. I don't know if that is true, but I just wanted to give you some historic background to those kinds of assumptions, that they saw some similarities with this incipient fibroadenoma-like lesions, which retained the lobular kind of configuration with the larger lesions. I don't know if this is accurate. Anyway, here is a summary of what a fibroadenoma looks like. So there is symmetric distribution of epithelial and stromal elements, uniform stroma, uniform looking stroma throughout the lesion. They have well circumscribed borders. You may occasionally see mitotic figures, and sometimes in younger patients, especially when you are dealing with the entity of juvenile fibroadenoma. But you know, the mitosis is never atypical. They are typical mitotic figures. And if anything, they are few, and generally they will be in the stroma around the duct, not so much well within the meat of the lesion. And then, of course, you know, this goes without saying that there is no stromal overgrowth. And I will define what is meant by stromal overgrowth in a minute. But if there is stromal overgrowth, then it is not a fibroadenoma on a needle core biopsy or even on an excision specimen. So I'll just spend a minute on describing juvenile, because this is like a distinct subgroup. I mean, these women can sometimes worry. I mean, you know, they are young girls, sometimes not even in their teens, and the parents get anxious because the girl may have multiple lesions. And when you look at the thing in the last slide, they're highly cellular, rapidly growing, you know, they may show mitotic figures. And it can be quite a distressing experience for this young girl, you know. And when you look at these microscopically, they are quite cellular, right? But otherwise, they will look like a fibroadenoma, you know, grossly. This is nicely circumscribed, encapsulated, you know, with this cleft-like things. You know, this is typical of a fibroadenoma. If you Google fibroadenoma, this is what you are going to see. These juvenile patients may get, like, they may assume big size, you know. And it's unfortunate because these girls sometimes don't have really much of breast tissue. All there is in the breast is this mass. And you are worried even about taking it out because you don't want the breast parenchyma to be removed, you know, with it. But these are encapsulated. You can shell them out easily. And they will kind of recapitulate many times, actually, although not always. They will recapitulate the lobular architecture of the memory tree. So you can see how, these ducts are branching out, throwing lobules, and then you have this stromal proliferation in the background. It will look like breast tissue with a lot of stroma in it, proliferating breast tissue with a lot of stroma in it. Now, obviously they are rapidly growing. There has to be a reason, right? I mean, it's not surprising that you will see mitotic figures, but don't get carried away in this setting by mitotic figure. Certainly there is no need to consider the diagnosis of phyllodes tumor because of mitotic figures. It would be totally wrong to think in those terms in a 12-year-old girl. Nicely circumscribed lesions. Now we will see the contrast, right? So on the other hand, phyllodes tumor, and I may use the term PT, that my throat doesn't go dry. These are uncommon. So I think the first thing to recognize about phyllodes tumor is that they only constitute less than 1% of all breast tumor. And in fact, only a small minority of all fibroepithelial tumors. And I think this is based on the observations made by Stout in the 50s. So I think when we see something that looks fibroepithelial, the first thought should not be phyllodes tumor in a needle core biopsy, right? Because I know that there is only a 1 in 40 chance that this fibroepithelial lesion is going to be phyllodes tumor. Most likely it is going to be a fibroid. So that is my starting point. It will take a lot for someone to convince me that this is not going to be a fibroadenoma. Now, having said that, I cannot rule that possibility out, and that is where we have to focus our attention on. Now, some of you will be surprised that this actual lesion was described like in 1828, almost 200 years, by a German pathologist, and he considered it to be benign. And it took more than 100 years for first malignant phyllodes tumor to be reported. So what does that tell us? The history itself is telling me, the timeline itself is telling me that even when I am dealing with a phyllodes tumor, what are the chances of it being malignant? I mean, if it was very common, right? Malignancy was very common in the setting of phyllodes tumor, we would not have had to wait for 100 years for first such example to appear. Now, like that, FEA and all that, at least in the early years, people were confused with what entity they were dealing with, because phyllodes tumor actually carried many names, like Hindu gods are, right? I mean, I read somewhere like as many as 62, and I lost that list somewhere. I can't give you all those names, but as many as 62 terms were used at some time or the other to describe the same lesion. So you can't fault people to be confused about this entity. But this is a classic image of a phyllodes tumor, cysto, right? Cysto. I will eliminate the sarcoma part, but since the term cysto part of the cystosarcoma comes from this cystic appearance of these lesions. They can be very cystic actually, and sometimes these cystic spaces may undergo even squamous metaplasia, and that could become like a pitfall, because somebody putting a needle into that cyst will come out with keratinous elements, and the diagnosis will be epidermal cyst, when in fact this could be like a phyllodes tumor. But anyway, now the other thing that this is telling me is that there is different areas can look different in this lesion, right? There are these areas which are to the periphery, and then others which look like this, and we'll see more of this as we go along the slides. Now, the early pathologists thought that unlike fibroadenoma, the stroma in these lesions arose in the periductal stroma, not from the perilobular stroma. And I think this probably was based on these kind of observations of those early pathologists from periductal stromal proliferations and things like that. But again, I don't think that we need to really spend too much time on debating that. I mean, there is no need to. I mean, it's not at all important. But I just wanted to give you some historical stories. So when you look at closely at a phyllodes tumor, again, the stroma will have to be quite cellular. They will throw these like grape-like or finger-like processes. That is where the term phyllodes comes from. Quite cellular, actually, the degree of atypia can be different, can be quite marked if it is malignant to kind of almost like fibroadenoma if it is at the very benign end of the spectrum. Oftentimes, the stroma will push these ducts and compress them. There can be varying degrees of epithelial hyperplasias in these ducts, but one should not spend too much time in looking at those epithelial proliferation unless something looks like DCIS to you. And that is another pitfall that happens in fine needle aspiration biopsies, because sometimes, as you can imagine, the stroma may be difficult to aspirate, but these ductal cells may be loose and they will get aspirated, and they may look quite atypical. And to a non-breast pathologist who is doing cytopathology on these cases, it will look atypical. And they may actually, I have seen cases where a diagnosis of DCIS is rendered by a cytopathologist when all it is a benign phyllodes tumor. So we don't want to, that's why actually, at least in New York City, a primary diagnosis of breast lesion is not made based on fine needle aspiration biopsy. Now, there may be no reason not to do something like that, but I'm just telling you, and there may be reasons why something like that, there may be a history behind that. But anyway, coming to the point of phyllodes tumor, you will obviously, in addition to a lot of cellularity and this kind of capillary proliferation and all, you will see mitotic figures. And the number of mitotic figures is used as a way to discriminate the spectrum of phyllodes tumor. Now, you may question the rationale behind that, given that even some fibroadenomas may have a lot of mitotic figures, but it is in the mix. It is one of the things in the mix that is used in discriminating benign, borderline, and malignant phyllodes tumor. Unfortunately, with time constraints, I cannot really go into great details of that discussion, but we will address some of it at least. Now, phyllodes tumor, as I said earlier, can be quite heterogeneous. So you can have areas where there is substantial epithelial element, some of being thrown into these finger-like things. There is a lot of stroma here, but the degree of stromal expansion may be even more in some other areas, to the extent that this may qualify as an overgrowth. Now, what is overgrowth? Overgrowth, by the way we define it here, is that if you go to your 4x eyepiece in the microscope, now I know that microscopes can be different. I don't know what microscopes that you use there, but at the lowest power, not 2x, but 4x, if you don't see any epithelial elements and you see only stroma, then that qualifies as overgrowth. So there is a quantitative measure for overgrowth. You can't just use the term overgrowth loosely, because once you say that there is overgrowth, fibroadenoma is out, and you are already now talking about at least borderline phyllodes tumor, or maybe perhaps even a malignant phyllodes tumor. So you have to use that term very judiciously. Now, sometimes given the heterogeneity in a specimen, actually this is from a phyllodes tumor lesion, but it had areas which were indistinguishable from a fibroadenoma. So if a biopsy is representing only this area, the diagnosis will be fibroadenoma, but the patient may actually have even a malignant phyllodes tumor. So this is a pitfall. And how to address that, we will come to that as we discuss this issue more. Okay, but I just wanted to show you extreme example. Now I don't want you to go away with the impression that this is going to happen all the time. No, these are rare examples, and this is probably only one example that I have in my collection, but I'm just highlighting that to make a bigger point. Okay, so here is a summary of phyllodes tumor morphology. So heterogeneous appearance, increased stromal cellularity, expansion, stromal overgrowth, the way we described, okay? And then cellular pleomorphism, varying degrees of atypia, mitotic. Now you may, in the classic case, have the leaf-like growth pattern, but it doesn't have to be there, because just imagine if the stromal proliferation has overgrown everything, right? It's going to remove everything, including those cystic spaces. So to the point that you may begin to ask whether this is a malignant phyllodes tumor or is this like a primary mammary sarcoma. There's not much difference between the two, at least not in how they are handled, but it may be more of an academic discussion and more to do with documentation of your diagnosis. Now, many times, especially in borderline and malignant phyllodes tumor, the borders of the lesion tend to be infiltrative. Most of the benign phyllodes tumor will have borders that are circumscribed and pretty similar to that of a fibroadenoma. So what are the questions here? So the recurrent questions are, is this a fibroadenoma or a phyllodes tumor? And that determination, a pathologist, at least in our practice in New York, or maybe in Europe, and perhaps also at least in certain settings in India, on a needle core biopsy, we are asked to make that determination. Is this a fibro? And why? Because if it is phyllodes tumor, the surgeon is going to excise. If it is fibroadenoma, they may just follow it up. So that's why it's important. Now, the other question, of course, is having made that determination, if you are lucky in a needle core biopsy, then the next question would be, is this benign or is this malignant? And this question you will also have to address on a surgical specimen. And I don't believe that this is straightforward many times. There is a lot of confusion here too. And I'm sure you will have a lot of questions when I end my story on this topic. Okay, so on a needle core, is this fibroadenoma or phyllodes? Now, unfortunately, we don't see this book picture of fibroadenoma in our needle core biopsies, right? I mean, this is only seen in textbooks. And it is seen in textbooks because these textbooks were written in the pre-stereotactic, pre-imaging biopsy area, where these lesions had grown to their full potential and were on their way out. What we are seeing now is actively growing lesion, which has been picked up by these imaging sleuths. I call them sleuths. In their early days, when they are now growing. So what you are likely to see is this kind of picture, with a lot of cellularity. And now I'm really up against the wall. Do I call this phyllodes tumor? Do I call this fibroadenoma? I mean, can I really make a definitive diagnosis? And you know how the surgeons are. They see everything in black and white. They don't understand our difficulties. To them, everything is written on the slide. The slide comes with the name written on it that I am fibroadenoma and I am, these are funny people. Okay, so the way out, of course, a reasonable way out for many of us would be to postpone the diagnosis, right? Just call it cellular fibroepithelial lesion and say that the differential diagnosis is between phyllodes tumor and a fibroadenoma. And this is something that irritates most of the clinicians is this thing when you write in your comment, clinical and radiological correlation is suggested. And of course, you will then end by saying that excision recommended for definitive diagnosis. Now, this is fine from our perspective, from our point, because we want to save our skin, right? So we have a vested interest in making this kind of diagnosis. But this doesn't help a surgeon. I mean, if you begin to do this often, trust me, you will get an email from a surgeon. And that surgeon, especially if he's an old timer, is going to ask you, hey, don't we ever see the good old fibroadenoma anymore? Because in his or her mind, the good old fibroadenoma that he saw in conferences was something that existed in the textbooks, that burnt out kind of fibroadenoma. And he is not really appreciating our challenges, right? I have been asked this question, Now, why they get irritated with us anyway? Because let's imagine that in this 25-year-old in a 1.8 centimeter mass, because I had only one core or somebody had only one core and it looked quite cellular and was a little bit disconcerted. Perhaps he or she saw a mitotic figure, kind of equivocated, right? And said, okay, let's have the excision. Now, and this is the often story, right? Most of the time what happens? The surgeon goes in, takes it out, and then, it's all a fibroadenoma. He will tell and then he will start keeping this in mind that, okay, this guy, Dilip, now I have seen 10 of his biopsies, he has equivocated, and 10 of the 10 times it has turned out to, so does this guy really know what he is doing? Right? That is the impression. We have to look at it from their point of view. That is why there is this need to struggle and fine-tune our approach. Now, the question, of course, remains whether we are smart enough to fine-tune on whether it's really going to be possible or not. That's a different question. Another example, now you are looking at all this, I mean, you are seeing this some kind of atypical. If you are a beginner, you don't recognize these as stromal giant cells. I mean, it's too busy for your comfort, and you call it, maybe something, Then they will excise and they will tell you, hey, this is fibroadenoma with sclerosing adenosis. Another example, I can't even be sure that I am dealing with fibroepithelial lesion for something like this, because to me, this looks like a papilloma, right, with fibrocystic changes. Now, unfortunately, what has happened here is that I'm only seeing a small fragment of the tissue, right? Now, this lesion could have been quite big. The radiologist has failed to sample it well for me. So I will only be able to know more about this story if I knew what the imaging picture was. Now, if in the imaging, I was told that this was like an oval mass, which is like parallel to the horizontal axis, and that the radiologist is in fact thinking that this might be okay, fibroadenoma, then I will have a different approach. But many times, either we don't have that information, but if we do have, we are lazy to actually look at the clinical details, and then we end up calling this something, blah, 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 and then they will go and excise, and then it turns out that this was actually a fibroadenoma with some unusual morphologic features or with some architectural complexity. So many times we can mitigate our problems by being more diligent. And by discussing these cases with the surgeon, and the surgeon has to be good enough to have a lot of interest in pathology and is willing and able to come and see at the slides with you and open his mind. But that is too much of a tall order. Okay, so now we are left with this question, can I call something as a fibroadenoma, or can I distinguish it and call something as a phyllodes tumor? Is there anything there? I mean, has anyone written on this subject? obviously people would have written, right? I mean, if I am asking this question, obviously others have asked and others have made some attempt. And there are a lot of people who do a lot of work, and their promotions are based on publishing and all. So there are many papers. So I will not share with you all those papers, but I will only share with you one somewhat recent paper from actually this is from Johns Hopkins. So in this study, they enumerated significant histologic features which differentiate cellular fibroadenoma from a phyllodes tumor on a core biopsy. So of course, they saw a lot of things which we obviously would have seen, right? But any one of these probably didn't help us. That's why we ended up equivocating in the first place. So of course, they found a lot of mitotic figures in 10 high power fields, overgrowth. Oh my God, I mean, that would be very rare. But if it is there, then all bets are off. Now, these are things, we see, right? And we'll see some of these in the next few slides. So Yasser and his colleagues enumerated these while addressing like a needle core biopsy. What they summarized these observations by, they summarized that by telling us that if you see 3 or more mitotic figures, right, in 10 higher power in a core biopsy specimen, or a total of 3 or more histologic features that have been described in this list, then you can predict a phyllodes tumor. Now, obviously, this kind of observations have to be subjected to more prospective analysis, right? So, I don't know how much appetite people have to do anything like that. I certainly don't have any appetite. I think I find useful other things actually than these morphologic things alone. And we will look at those later. But anyway, so I think this is something that is a good starting point. You can certainly use these. People have scientifically looked at these. So I think that makes good, intelligent approach. Okay, so mitotic figures in fibroepithelium. If you see many of these, then you should ask yourself before calling something fibroadenoma. If you see this subepithelial condensation, then I think the authors tell us that worry about phyllodes tumor. But I must tell you that I have seen this also in what eventually turned out fibroadenomas. The one thing that I have found useful is this circumscribed border. So if it is benign, certainly fibroadenoma, or at the benign end of the phyllodes tumor, then the borders of the lesion is going to be circumscribed. The problem is that you don't always see the edges of the lesion in a core biopsy, depending on how it has been sampled, right? If you see infiltrative tendencies in a needle core biopsy, then obviously, you can eliminate fibroadenoma from the mix. So if it is a well-sampled specimen, and if all of the cores that show this fibroadenoma show me a circumscribed edge, then I'm happy to call it a fibroadenoma, regardless of the cellularity. Now, just to warn you that you should know what exactly is meant by infiltrative edges, right? So this is not infiltrative edge. This is just incorporation of fat by some kind of collagenizing process that is going on a long time, and this can happen also in something like PASH. So you should know what you are looking at. You have to first make the determination that you are looking at either a fibroadenoma. The question is either fibroadenoma or a phyllodes tumor. Now, obviously, if you don't have too much experience in breast pathology, then even this you will not recognize. But I cannot really solve your problem there. Now, this is what they mean by fragmentation. When you begin to see like epithelium, with a space outside on a fragment, then this is something, the fragmentation is more likely to be seen in a phyllodes tumor. And it makes common sense as to why this will happen. For example, if you put a needle in this phyllodes tumor and you get a specimen from this, right? This is going to throw these fragments, and this will be seen in our slides, something like this. On the other hand, that's not what is going to happen in a fibroadenoma, because the needle is going to tear this stroma. You are not going to see this kind of nice epithelium on the edges of the tissue. So here is an example, a needle core biopsy with this kind of fragmentation. So am I confident to call this phyllodes tumor? Based on that paper, yes. And it does turn out to be a phyllodes tumor, right? So once it's a phyllodes tumor, the other question, of course, you have to address is how far is it from the margin? I don't have time to go into that, but I'm just explaining to you why this ink is there. Now, if there are these pseudo kind of fragments without any epithelium in a core biopsy, that you may see, but that should not be regarded as fragment, because you will see this kind of artifactual changes even in a fibroadenoma. Okay, so if this is trapped in the needle, you will see a fragment, but that is not the fragmentation they are talking about in that paper. We have to be able to make that determination. What fragmentation am I seeing? Okay. Now I think we, having looked at all these morphologic things, the other important factors to consider actually in evaluation, and I find these actually very helpful. And I never actually, in fact, I never look at any of my core biopsies unless I have all the information in front of me, whether it is a fibroadenoma or it is any other biopsy. The age, I just want to know the age of the patient. If I am looking, if I know that this is a 70-year-old female, okay, I don't care what the biopsy is showing. If it is cellular, I want it out, okay? Even at the risk of it being called a fibroadenoma, there is a chance, there is a greater chance actually that it, but you know, I feel uncomfortable in a 70-year-old for stromal proliferation going on, and only I have like a small sample of it. Now this would be very different if I am told that this is a 25-year-old woman and her lesion is only 1 centimeter in size, and I'm having 5 cores of tissue, and the radiologist has probably already cored out in the entire lesion. What more am I going to see other than what I am already seeing in the biopsy? So the size of the lesion, the age of the lesion, am I convinced that this is a fair representation of the lesion in my biopsy? I think all these questions are extremely important, because if the stuff looks cellular, but it is like looking kind of benign, and it's a small lesion, and it's been fairly real, what more logically can you expect to see in the excision? Now, on the other hand, if it's a 7 centimeter lesion, and the stingy radiologist has given me only like a small fragment of tissue, I can't be sure, because we know that phyllodes tumor can be very heterogeneous. So I will either ask for a rebiopsy saying that sampling errors are possible, or if the radiologists and the clinicians want, they can just excise it and put, you know, an end to the story. Okay. Now the other things that go into the mix, and this is also important for us to know, is the history of prior fibroepithelial lesion like a phyllodes tumor, benign, malignant, or whatever, or if this lesion in the interval has increased in size, right? So if something 6 months ago was 1 centimeter in size, and for whatever reason now the patient has been imaged after 6 months and has become 3 centimeters in the size, and it still looks similar to what I saw in the early biopsy, I think it makes sense to get that thing excised, because as you will see in some of the other pictures that I will show you, you are now in risk zone. You know, something is growing, and I think it's best that it is taken out, and I think that will probably bring comfort to everyone. And the imaging findings are very important, because oftentimes, you know, these radiologists, they already know what there is. They already know that it's a fibroadenoma. So now you don't want to create confusion in the, because, and the other thing is that they may already have told the patient that this is a fibroadenoma, most likely. Now in a biopsy, I don't want to open a Pandora's box by, dilly-dallying and equivocating, and then this really, at least in the US, the women, and anyone, even I would be very anxious. And the women get anxious, oh my God, what is going on? Oh my God, what am I going to do? They will see 10 other pathologists. It creates a lot of confusion for everyone. So I think for the sake of sanity and balance, I think don't make a diagnosis unless you have in your mix all of these things. I have seen cases, believe me, I have seen cases of a fibroepithelial lesion being called chronic inflammation in a needle core biopsy. But because I knew what the radiologist was seeing, I suggested that I'm seeing chronic inflammatory changes in this tissue core, but this, this should be rebiopsied because I'm not really seeing what I should be seeing that would be representative of the lesion. And lo and behold, the next slide gives you an answer. Okay. Now I think with this, we will look at some real diagnostic pitfalls. And these are real cases, These have happened actually. These have happened in New York. Okay, so here is a core biopsy in a 70-year-old female. And, it looks quite cellular. Doesn't look very atypical, but, some of these cells do look somewhat dark. But there is good population of benign ducts, and it appears to be fairly uniform. Certainly no overgrowth, no nothing of that sort. Not really much of by way of mitotic activity. Another picture, same, the cytologic ATPI is not screaming at us. And, some degree of cellularity, this is from a fibroadenoma, juvenile. So you would think that, okay, it's not a big deal. It could still be some sort of a fibroadenoma, right? But of course, you may not have answered many of those other questions that I had in my slide, because if you had answered those, you probably would not have made the diagnosis that was made here on the core biopsy. So the diagnosis was cellular fibroadenoma. Of course, wherever this diagnosis was made, because the radiologists only saw the term fibroadenoma, said that maybe it is okay to wait, But, the patient didn't have to wait much anyway, because within 4 months, she came to us. And she came to us within 4 months with a lesion that was growing so fast that the surgeon actually had to sacrifice the skin in this case. So no fibroadenoma will surgeon have to remove the skin. And this looks very different. Looks so different that I'm not even seeing what I saw in that biopsy. It's looking like a sarcoma already, with a lot of infiltration and all. There's necrosis here actually. So this is actually a sarcoma. Can I say it's actually even like a malignant phyllodes tumor? Not based on the slides that we have seen so far. But the funny thing that happens in these lesions, as I said, is that they are heterogeneous. And as you move to the periphery, of this lesion in this particular case, you started seeing ductal elements with malignant stroma in the periductal area. So now you begin to believe that, yeah, this is some kind of malignant fibroepithelial lesion, and it has been overgrown by these sarcomatous elements throughout. And this is only seen to the periphery. So much so that if you pushed even further along, you will now begin to see what was probably seen in the core biopsy. So look at the contrast. This is that ugly sarcoma, and this is the edge. This is the so-called capsule of that lesion. And the biopsy probably came from this area. Now, this is another example, this kind of thing happens sometimes actually. And that's why it's important to know what the lesion really looked like. So here is another case of a malignant phyllodes tumor, where the core itself is totally malignant. I mean, it is wild, as you will see. And yet, there is like a dense collagenous capsule of a fibroepithelial lesion at the edge. Now imagine what would happen if the radiologist needle only sampled this area. You will not see any of this, right? You will only have seen this. But if somebody told me that this was something rapidly growing, I'm not going to call or whatever I see here. I mean, I'm just going to say that I don't think that I'm seeing what I should be seeing here. Because you see, I mean, this is like a wild sarcoma, which is growing in a rapid way, but it's pushing everything around. And if you are, even in this case, actually, as you went to the periphery of the lesion, the highly malignant area, there was that transitioned into a more kind of a periductal fibroepithelialish kind of appearance. And if you went more and more to the periphery, this is what happened. Now, whether or not you could call this malignant, benign, that's a different question. We know it is malignant. So much so that at the extreme end, you may actually start wondering whether this is sclerosing adenosis or something, something like that with some stromal giant cell. So, I mean, don't be alarmed by these two illustrations. I mean, these are two in my collection of many cases. But I think there is a lesson to take. Now, in some rare cases, it may truly be difficult to predict the nature of the lesion based on a biopsy sample. This may truly be a problem. And how so? So to illustrate that, here is an example. This is a young girl, right? 14 millimeter mass. I mean, it appears to be a fair biopsy. It's circumscribed. I mean, it almost looks to me like a juvenile fibroadenoma or some sort of a tubular adenoma. I mean, it had some areas where it looked a little bit, somewhat different from what you would want to see. But here again, stroma looks very benign. So now, you are balancing between what to call it. So anyway, to cut a long story short, this was called a tubular adenoma or a fibroadenoma at that time. Now, at this time, remember, this was 14 millimeters in size. So now, 2.5 years later, she comes back. Now she comes back. The mass, of course, has grown. It has more than tripled in size meanwhile, okay? In 2.5 years. It's probably become palpable for this woman. And now it begins to look quite different, although it still has some areas which look similar, but it's clearly different, There is a lot more stromal component, and probably some of which it is quite atypical, and yet it's having also some areas which look like a phyllodes tumor. Now this is serious stuff, right? I mean, even in this one field, I have got many mitotic figures, and some of these are tripolar, atypical, and these cells are looking malignant. So this woman who had some 2-3 years ago what looked like, at least on biopsy, like an adenoma or a fibroadenoma, is now showing up as what could be argued as a malignant phyllodes tumor. So what went wrong here? I'm not sure if anything went wrong. I mean, there are some historical anecdotes where malignant phyllodes tumor have reportedly arisen from a fibroadenoma. Now, how accurate those reports are, that I don't know. But what else could have been done, other than warning the woman to come more frequently? Sometimes, women take it for granted, and even if they are advised, they may not come. They may only come when something, because they don't understand the seriousness. So in this case, she probably came when the mass became palpable. Anyway, so cut a long story short, and I think this is quite humbling, you know, when it comes to fibroepithelial lesions, why do mistakes happen? In my experience, the number one, the most important reason for failures is our failure to have clinical and radiological findings. I think it's really unethical, you know, to work without all the clinical details. The other problem, of course, you know, as we saw in some of these cases, is that phyllodes tumors by nature, you know, they have a wide spectrum of morphology and heterogeneity. But I think some of this issue can be resolved if we take care of this in the beginning. Okay, so I have finished my discussion on fibroepithelia. So there is, I'm sure there are questions, and we can address those.
So for this case, we are not seeing any specific question.
Okay. Okay, good.
We can move on.
Dilip, I just
Yes.
wanted to ask a question because it's based on, well, I don't know, experience maybe no evidence-based knowledge. That it depends on, particularly in young women who are cycling, okay,
Yes.
or somebody who's just gone into puberty and has a fibroepithelial lesion, you will find that depending on what phase of the menstrual cycle, or you know, if the patient is just gone into puberty and is not cycling, but obviously there is a lot of estrogen around, you will find that the stroma of these lesions, which are fibroadenomas, are really quite mitotically active.
Yes.
Yes, and I don't know whether there is evidence in the literature. But I know one thing, that in young, very young women, like your 14-year-old girl, I would be very loath to call anything more than a fibroadenoma, no matter I saw, 3 or 4 mitoses in that core, because I feel that estrogen has to be put into your mix, as you call it. It's a very powerful, sort of driver of both stromal as well as epithelial proliferation, and we need to take that on board, before we start calling things. I have no evidence about whether, if this has been biopsied during the estrogen phase or the progestational phase, but biologically, I think that this does make a difference. I don't know what your thoughts are on that.
No, I think, yeah, you have well made point. I mean, as a rule, in a young woman, you want to be conservative. Personally, I have seen many cases in young girls with a lot of mitotic figures, actually more than 10 in 10 high power fields.
Exactly.
Which is like the extreme. But even those cases, I have called them fibroadenoma. And they are conservatively followed, and unless later they increase in size, they seem to be doing fine. So yeah, I mean, the age is extremely important. And those cases of juvenile fibroadenoma that I showed, they tend to have, they seem to be rapidly growing, and they have a lot of mitotic figures, but they're, they will quickly reach a stabilization stage, and then the growth will be arrested and everything will stop. So you don't want,
So I think, that the point has to be made that, the number of mitoses that people talk about in the stroma has to be, taken with a fistful of salt if you are at an age when, you're just bathed with estrogens. I think that is something that all pathologists should take on board. And I've seen some really sad things that have happened, when people have taken out these lesions, and I felt that the breasts have become lopsided because somebody just counted mitoses.
Yeah. No, I think this is a very, very important point for the trainees in pathology and also for early careerists. You have to, it's not, whatever sometimes the books tell you or papers tell you, don't go by that alone, or be humble, have this attitude of learning from your experience by other people's observations, go to your seniors. I mean, we have outstanding pathologists in India, and I'm sure that they are available and willing to help you out. So I think we have to be quite balanced in how we work, and that is how we learn. There is no other. I mean, sitting in this lecture is not going. You're not going to benefit that much. It's only what you see from your cases and over a period of time. That is what is going to make you a good pathologist.
Yeah, I think we'd like to carry on, Dilip.
Yeah. Okay. Now we are already into 2.5 hours. So I'm sorry that I'm taking a lot of time. But anyway, case number 4 is a 55-year-old with a 17 millimeter kind of suspicious looking mass. Okay. So Purnima, let's give a shot. Just tell me what you see here. Okay. Okay, Gautami.
Yes, sir. So this is a low power examination of breast biopsy that has 3 cores. In this, focally, there is increased proliferation of gland is seen compared to stroma.
Yeah. And how would you describe this versus this?
Sir, in that proliferation of ducts are more compared to stromal proliferation, and most of the ducts are compressed in it.
Okay. What else do you see? What do you think about this? So there are some sclerotic changes here, right? There
Yes,
are
sir.
some distorted kind of glandular structures, which are trapped
Yes, sir.
or which are present within this stroma. But there is this radially arranged kind of proliferative ductal, kind of process.
Yes, sir. Yes.
So from this itself, we are kind of heading towards a diagnosis. So this is one component, right? So this component shows like an adenosis kind of picture, which we would see generally in sclerosing adenosis.
Yes, sir.
And this is something very sclerotic, I mean, at this power, we are not now seeing that nice radial arrangement, but we are now seeing what would point to our diagnosis. This is all benign. And the diagnosis here, of course, is radial scar and sclerosing adenosis. Now, the radiologists, of course, because they are seeing a speculated mass or a speculated lesion, they are kind of worried because, generally speculation is associated, for them at least, with cancer, with invasive carcinoma. So they will be relieved when we say that this is a radial scar, because they do recognize that radial scars may also have that similar speculated appearance. So there will not be that much of discordance between our diagnosis and theirs. Although initially they may kind of worry about what they are seeing on imaging. Now again, we have to also ascertain that the lesion has been well sampled, because sometimes these scar-like lesions may have other things going on, as we will see in a minute. Okay, so here is another biopsy that we saw here. It looked kind of elastotic, scar-like. There's not much else happening actually here. So what is it? I mean, cursory look, even at high power, didn't yield much. But when you because now you are going crazy. Why am I not seeing anything? How do I explain this kind of highly reactive stroma? So then you as shown in this arrow, you will begin to see this very minute gland-like things, right? With nests of cells or glands-like cell. Oh my God, what is this going on? This is not something you expect normally. So now, you at higher power, you'll begin to see more of these better. They have some prominent nucleoli. Now, of course, if you do immunostains, this is a cocktail, a mixture immunostain, which has not only keratins in it, but also P63, which is a myoepithelial marker. So this is often used in our practice whenever we have question of invasion, because what this stains allows us to do is to look at the myoepithelial presence of a myoepithelial layer as is seen in this benign duct and the epithelial cells. And if you see absence of that myoepithelial layer, as you can note here in these nice small clusters or gland-like structures, so this is an invasive carcinoma. So sometimes, when you don't seem to see much and before you kind of dismiss something as some like a scar or a radial scar or something, I think it's important to take a close look because mistakes have happened actually in this kind of setting. So this is the excision. So this is a peculiar case because it has minimal invasive carcinoma, although there is invasive carcinoma. Now, how the management should be done, that's not something that we worry about. We worry about getting our diagnosis right because our credibility also lies on that. So here is the excision with all fat necrosis is because of the biopsy. And again, the ADH5 stain will boldly, bring out even those components that were not visible readily on the H&E stained sections. So now you can feel comfortable that this is a well-differentiated invasive carcinoma. And there's another case which my colleague across the street got in his consultation. So this was actually called as a radial scar by the outside pathologist, but this is another example of a tubular carcinoma. And you have to base your diagnosis based on how these atypical glands are distributed. Okay? In that example of radial scar that we saw, look how the arrangement was, right? So that's something to learn from this kind of case. So obviously the pathologist who on the outside rendered this diagnosis was also a breast pathologist, but we always learn, right? I mean, we always make mistakes, and that's how we learn. So even with our experience and all, we could make mistake, and I think we have to be open about it. But of course, my colleague from across the street made the right diagnosis. He shared this case with me, and this happened only a few days ago. So I just thought to bring this case along because this is something very recent. A diagnosis of radial scar made by a breast pathologist, and then later on a correct diagnosis of tubular carcinoma rendered by another breast pathologist. Okay, so I think since we are running short of time, I would rather finish up the cases, and then if there are questions, we will deal with them because I am already now 12, it's 12:15 for me. Okay, so this is in an older woman. This was like a mass, spindle cell mass, short fascicles, small nests of fusiform cells. These look quite bland and benign. There is some fat within this lesion, a lot of collagen here, no mitotic figures. So this diagnosis here is that of a myofibroblastoma. So here the diagnosis is confirmed using immunostains. Desmin, which is a muscle marker, is because these myofibroblastic cells, they have myoid differentiation. They will express not only smooth muscle actin, but also desmin. Because they are myofibroblastic, they will at least to some extent express CD34, which is a marker for myofibroblasts. They will be keratin negative because whenever you deal with a spindle cell lesion in the breast, it's important to consider the possibility of a spindle cell carcinoma in the appropriate setting. And I think here, just because of an academic exercise, I'm showing you a keratin stain to show that these cells are keratin negative. Now, what is interesting, and sometimes a cause, and as we'll see in the next few slides, a cause for confusion is the fact that these myofibroblastic cells can also be strongly ER positive because they are hormonally responsive. And this can become actually a pitfall, as you will now just see in next few slides. So here is a core biopsy that looked something like this. So it had these kind of epithelioid cell which are growing in Indian file almost, single file kind of pattern. And they look quite epithelioid actually with cytoplasm and all. Now, it turns out that in this biopsy, there was also LCIS, as you can see in the specimen. So the association of LCIS and that kind of picture, again, I'm showing you the Indian filing and all, a diagnosis of invasive lobular carcinoma was made. I mean, I don't know how you can fault the pathologist. You can fault because we will see what went wrong here. The ER, of course, was ordered because the diagnosis was already made. This is invasive lobular carcinoma. It's ER strongly positive. I don't remember the PR. It may have been positive or negative. And the HER2 was also negative, as you would expect in a log. So nothing. The surgeon also didn't think too much because, after all, surgeons also don't practice due diligence necessarily. So anyway, so a lumpectomy with a sentinel node biopsy was done. The same exact picture in lumpectomy, right? This is the core biopsy, same picture, same ER positivity. So now, is this a lumpectomy specimen of invasive lobular carcinoma? Somebody thought that something was wrong here. So that wise person thought that there was something that didn't make sense. So he looked at the whole mount of the slide. So this is a nodular kind of lesion in which the epithelial elements are kind of pushed to the periphery, and this kind of proliferation is going. This is not how you are going to see an invasive lobular carcinoma. This is something, if anything, you might see in a fibroadenoma or certainly in a benign kind of a stromal lesion. So that's where the scrutiny began. So there is all this fat incorporated, the epithelial elements kind of laid at the periphery. So this is all typical of a myofibroblastoma. So now, of course, when on further scrutiny, when it turns out that the cells, those cells which were ER positive are actually keratin negative. It's a nice inbuilt control here. And of course, we have seen already that these were actually desmin positive CD. And also the imaging was that of an oval parallel to the horizontal axis kind of mass. So somebody already knew this was benign, but somewhere there was miscommunication and the patient ended up with a sentinel node. So a lot of anxiety went on, right? But at least finally the patient is probably comforted to know that all along she had a benign lesion. She had an unnecessary sentinel node biopsy. That could have been avoided, even at the level of the core biopsy, if somebody had seen and talked to the radiologist. Anyway, and we come to the next case. So this is again a very solid looking, sheets and sheets of highly cellular kind of lesion, which is infiltrative, a lot of cytoplasm, some new prominent nuclei, very granular looking cytoplasm. There is collagen here, no in situ or anything, just this. Some, So now these can actually on FNA be tricky, A cytopathologist, when he or she looks at these kind of cells with this very kind of, abundant cytoplasm and all, especially if he or she is not a breast pathologist, may actually be led into wrong diagnosis. And that can, but of course, this is a granular cell tumor, this is S100 positive, and no problem here. But how these mistakes can happen? Because first of all, even grossly, this is a whole amount to show you that these lesions in breast particularly can be speculated. So even your gross impression will, and even a clinician's impression will be that of a malignant lesion. Even a radiologist may be thinking. So when the surgeon FNAs this kind of lesion, and an inexperienced cytopathologist is interpreting, he may call that as at least atypical cells, or may even call that as an apocrine carcinoma, because these will be discohesive cells. But of course, that will not happen if someone like Anita is looking at the FNA, but others might fall in that trap, and they have fallen into that trap. So even a grocer might think that I remember seeing this when I was a first-year resident here in New York at Downstate Medical Center. There was a specimen looking something like this, with skin on top of that and muscle at the bottom. And to my mind, the gross impression was that of an advanced cancer, because at Kings County Hospital in Brooklyn, that was the one place where in New York you got to see what we see in the third world. So to my mind, that was of a picture of a big carcinoma, but I was surprised when I saw the glass slides, because they looked exactly like that granular cell tumor. A fine needle can lead you astray. So here is an example of apocrine carcinoma. You can imagine how this can be tricky, right, on FNA. But keratins will seal the diagnosis. Okay, and the last case. This is in the 53-year-old linear non-enhancing mass, linear non-mass enhancement. Okay, so this is a curious incidental finding, right? So most of these non-enhancing or enhancing non-mass lesions and all in MRI biopsies show nothing. So this just shows an incidental finding. This has nothing to do with their enhancement, but it just caught my eye. And I wanted to share this with you, because I recognize that some of the trainees here may not have seen this phenomenon. So these are very small glands which seem to be growing into the fat. They look very bland, but they look infiltrative. So this could be mistaken as a tubular carcinoma or a small invasive carcinoma. The only difference is that it's not. This has some kind of rounded glands also, which are filled with some pinkish kind of material. Seen better on this high power. So, although they seem to be infiltrating fat, most of them, they look quite bland. They have this very distinct eosinophilic signature. They are rounded for most part. In the diagnosis, here is of a microglandular adenosis. So why did I bring this? So in addition to showing this to the trainees, I wanted to show you this because, of course, you can use these stains to confirm the diagnosis. Now, the problem with these lesions is, and I think you have to be aware, is that these small glands will not have a myoepithelial layer. And if you are thinking of an invasive carcinoma, but you are not familiar with this entity, then you will be led to a wrong diagnosis. So this could become like a pitfall. The use of these stains will become pitfall. See how nice the control benign does. So you would think that, oh yeah, this is invasive carcinoma, no myoepithelial layer. No, but the stain that you needed also to do was S100, because these small glands, they are almost always S100 strongly positive. They have both cytoplasmic and nuclear staining. Now it's important to remember that S100 is also a sort of a myoepithelial marker. Actually, some of you may not know this, but one of the first myoepithelial marker to be described, the days well before P63 and all these other slew of markers, was in fact S100 and also GFAP, glial fibrillary acid protein. These were the first myoepithelial markers that were described. So it's not surprising that these are. So what exactly this signifies, I don't know. It's a characteristic of MGA, and it's used to clinch that diagnosis. Now, this can become problematic when you have it, and there's a lot of questions around this MGA and all, you know. I think some other day we can discuss this. But anyway, there is sometimes these MGA or microglial, they can become atypical, as you can see, right? So this becomes a real problem because now these are looking malignant, and now you are doing myoepithelial, so you are convinced that this is an invasive carcinoma. And unfortunately, what happens is that these are triple negative. I'm showing you this ER. So now from something about whose potential you are not even sure of, you are ending up, especially if it's a substantial lesion seen on imaging, you are ending up with a diagnosis of a triple negative breast carcinoma. And straight away with that diagnosis, at least in New York, these patients will be referred to an oncologist. Because these days, you know, almost all triple negative cancer and even the HER2 enriched cancers get neoadjuvant chemotherapy followed by surgery. So these patients will end up getting a full course of neoadjuvant chemotherapy. At the end of the neoadjuvant chemotherapy, they will have imaging which will show slight or no change. Slight or no change. Why? Because the neoadjuvant was not going to act on this anyway. I mean, you had to get the diagnosis right so that the next step would have been excision and the confirmation of diagnosis and end of story there probably. So that's why I brought this case. Now again, you know, these are very rare. I mean, Memorial is one of the biggest cancer hospital in the United States, and we see a lot of breast cancer. So we don't see these lesions every day. I mean, maybe, I don't know. As a group, maybe a few times a year. So don't be alarmed, but be mindful. So this case, as you can see, S100. The other stain that some people use, I mean, I'm not very fond of it, is the use of this, you know, collagen 4 and laminin basement membrane markers. So at least in this case, it seems to highlight the contours of those glandular structures and therefore suggests that this is non-invasive. I'm not sure about that, but that's where it is. And I think I would like to thank you here and for very kind and patient hearing. And I can now throw the forum open for questions, if there are any. Otherwise, it's late in the day anyway.
So there are no
Well,
questions
thank you
in the
so
chat
much,
box.
Dilip, and let's ask the chairpersons to make some comments. Dr. Jaison or Dr. Zillur, would you like to say something about?
Yes, thank you, Dr. Dilip. It's a great experience from your side. We have enjoyed for last few hours, but as it is very late, I am not going to comment in details. So one thing that the first case was discussed in very details, that there are usual ductal hyperplasia which might be confused with invasive DCIS and ADH, and we have learned also that more than 2 ducts or more than 2 millimeter is not that much effective tool for the high-grade lesions, and we can consider it that there is borderline epithelial lesions, and we have to exclude these things. And another case that was very interesting, that is flat epithelial atypia, or the columnar cell changes with atypia, which is actually etiology unknown, and it's very tricky case, and they are dilated acini, there is calcification, and other cases are also interesting, but to me, the last case was very interesting, that microglandular adenosis, and the stains you have shown regarding the S100 using for myopithelial cell, it was also very interesting for me. So there was a great brainstorming today. I like to thank you. Thank you all.
Thank you, Dr. Zillur. Dr. Jaison? Dr. Jaison, are you there?
I think we can't hear him, yeah, even if he is there.
Yeah, I can't hear him.
Anyway, Anita, if you permit me, I'll just make one final comment. That,
yes,
you know,
please.
as shown in this slide, I can only share with you what I have access to, right? Like if you come to New York, this is all I can offer, whether you like it or not. So similarly, you know, what I have discussed is based on my practice. Now, granted, we work in a very controlled setting, and the conclusion that I may have made may not necessarily apply to the Indian situation. So we have to be very, very mindful, and we have to draw on the expertise of the Indian experts on how to deal with the challenges that they have in their everyday practice, and not simply blindly listen to whatever I have said as some sort of God's word. I think that's where I would end.
Dilip, there is an interesting question that has been asked by somebody called MM, sharing a personal anecdote. Her aunt was diagnosed as flat epithelial atypia, and several years later developed lobular carcinoma in the contralateral breast. So the individual wants to know whether there is a relationship between FA and lobular carcinoma.
Yeah, so I mean, one would expect that because ultimately flat epithelial atypia is in some way, at least at a molecular level, related to the LCIS and the cells constituting LCIS, it would not be surprising if such a person who has something going on anyway, like should develop long-term invasive lobular carcinoma in the other breast. Now, this could also be perchance. I think what I can say is that based on the Mayo cohort, it doesn't seem to be a strong risk predictor. Now, obviously there is a lot to be learned from all these, but it's not surprising. I think, after all, FEA is something like a mini ADH, right? I mean, if we look at it at an intellectual level. So just like ADH is it heightens your risk to develop cancer in lifetime. And who knows, the FEA may have been associated with ADH or even DCIS, although that was not detected. So these are hypothetical questions, but I think that we cannot totally rule out that relationship, but there is no evidence, no published evidence to suggest that, yeah, it definitely raises, there is at least based on the Mayo study.
Well, anyway, it remains to me to thank you very much, Dilip, for having been very sharing so much of your material, but also being very open to ideas and concepts that are not, you know, that seem to be set in stone in some of the textbooks, but you have, you know, tried to elucidate the problems that some of these ideas may actually throw up. Thank you for that, because I think these kind of what we try to do during the online teaching program is not just to give dogmatic ways of dealing with problems or dealing with everyday pathology, but also to open the minds of the listeners to the possibilities that they may not have considered, or maybe the textbooks, which are hidebound by tradition, will not open their minds to. And I think in that respect, I think you've done a great job, Dilip. I say this sincerely because I've always found you to be of the mold where you think rather than react. So thank you very, very much, Dilip. I think there have been lots of compliments in the chat box and a lot of thanks from those who have listened to this program. And I feel that one of the great things about this online teaching program is that there are no limits to learning or teaching. So, you know, time is stretchable. And that's also something that I thank you for, spending a lot of your time trying to teach and elucidate concepts. So thank you very much indeed.
Thanks for those kind comments, Rita. After all, whose student am I?
No. I've had students and students. So I can only say that I'm so glad that you were my student.